program, we are supposed to be having a recap. But we have said, no, that one will not be part of what we are going to do today, this morning. After all, the whole package, the Secretariat is compiling everything for us at the end, okay? So what you got yesterday is what you can recap for yourself. If you attended half day, that's it. You'll read the rest when we give you the report. If you didn't attend at all, I don't know, ask your neighbor. But you'll get the package at the end. So this thing of recapping and generating more questions, no. We have a keynote speaker for this morning by our DHO Emeritus, Dr. Paul Awil Onek, and he's here with us, and he's ready and prepared to start. And the session chair there is Dr. Janet Owola, the chairperson of the DHOs in the region. And she is also ready to start. Immediately after that, because we are giving Dr. Paul, there it's written 15 minutes, but this being a keynote address, I think I'll give you about 20, 25 minutes roughly, okay? About 20, 25 minutes roughly, since we don't have recap anyway, so you can take that time. And after that, please, we are breaking off immediately. There's no break tea after that plenary presentation, that keynote address. We break off immediately to the two break-off sessions, the break room sessions, Elephant Hall and Ballroom Hall. Dr. Dennis Ochula will take chair here in Elephant Hall, and Dr. Laina Samandu will take the chair in the other room, ballroom. And so I expect the presenters for those sessions to be ready as well. First of all, I must say thank you to the presenters of yesterday, because we had all the presentations for yesterday. We didn't miss anything. And we also expect today to be the same. So that means, yeah, thank you for the presentations. And I also received reports that the quality of presentation was very, very good. The information therein, much as some of them had too many slides, but remember, they had to get a lot of information in just a short time. So please bear with some of the presenters there. But the quality and the scope of the presentation and the participation of members was really, really very, very impressive. So we say thank you for that. And we expect us to continue with that today. But also as we go along, there's a form here from the Ministry of Health, which is reviewing the package of service. I believe all of you have received a copy, okay? So the ministry is saying, please rank those services, put your opinions down, rank them, and hand over that to, where is he? And hand it, yes, and hand it back to him. The earlier, the sooner you do it in this 1 or 2 minutes, as you look through page 2 and you rank it and give a score of 0 to 3, and you can see the instructions are there. I believe you can read through and you follow. So please write that, fill it up with your title and your district, and please hand it back immediately for him to take it back. And as we start, I would request that we put ourselves in a short prayer for today, okay? And I ask Sister Liberata, who is the Diocesan Health Coordinator for Gulu Archdiocese, to lead us in a short prayer. Sister, can we get a mobile microphone, please?
My dear brothers and sisters in Christ, without Christ, we are nowhere. I request you to follow and to allow me read just a text for today from St. Luke. I know we are time bad, but let us give this minute to the Lord. The Gospel of the Lord. Herod the Tetrarch heard about all that was happening, and he was greatly perplexed, because some were saying, John has been raised from the dead. Others were saying, Elijah appeared. Still others, one of the ancient prophets has risen. But Herod said, John I beheaded. Who then is this about whom I hear just things? and he kept trying to see him. Let us pray in the name of the Father, of the Son, and of the Holy Spirit. God, our Heavenly Father, we thank and praise you for every moment in our lives, for your protection throughout the night, and you opened for us a new day. Thank you for all the deliberations of yesterday and today as we go on in the second day, still with the effort of improving health services, that is quality and standard, in our community, in the country at large. We ask you to lay your hands on all those activities and all our intentions of today, our desires, that whatever we are going to discuss here may be of benefit for the people that we are going to serve. Help us as an individual, give us enough wisdom and the strength to go through the activities. We ask all this through Christ our Lord. In the name of the Father, Son, and the Holy Spirit.
Madam Chairperson, you can take the floor. Dr. Neck, please.
Good morning, everybody. I hope you had a lovely night. Gulu City was very warm yesterday and welcoming. We have the honor to be given the keynote address for today by Dr. Paul Awil Onek, the DHO Emeritus, Board Chairperson, Gulu Regional Referral Hospital, Public Health Specialist and Health Services Manager with over 42 years of experience working in the districts and regional level. He worked as a medical officer in various district hospitals and later Gulu Regional Referral Hospital, where he was promoted to the medical superintendent. He was later posted as the district medical officer at that time. They were called district medical officers of the Greater Gulu district, where he worked for 33 years. He's best remembered for providing health and sanitation services to the internally displaced persons camps during insurgency in northern Uganda and effectively managing the Ebola outbreak in the Acholi region and good health partners coordination. He's currently retired but not tired, and is a member of the board of St. Mary's Hospital, Acholi, in addition to what I already told you, chairing the board of Gulu Regional Referral Hospital. Can we welcome Dr. Paul Awil with a hand clap? You're welcome.
I don't know those things. Good morning, ladies and gentlemen. Let me start by thanking the organizers for inviting me to attend this very important referral assembly. I really appreciate this presentation of mine. Of course, I made some consultations with the Dr. Dong, Director, Lacho Hospital, and I made the consultation with Director James. And of course, I discussed with some of you. So it will not purely be my opinion. And this is the first assembly, so I'm going to raise more issues than answers on the health referral system. I'll raise more issues than answers. It will give you a stimulus for discussion, policymakers, to make their policies, and you implementers to see the gaps, so that if there is a second assembly next year, we shall have improved on this presentation. We shall have come with a better paper. So this is not cast in stone. I've left some questions unanswered deliberately. Next. That is the presentation. I'm going to give you an introduction. Then we shall look at the referral system. Then we shall look at constraints and challenges. This one I will peruse through. It will come mostly from you. Then, of course, we give some recommendations and way forwards. And again, most of these recommendations will come from you. That is a very important diagram. That's a very important map of the Gulu, the Acholi sub-region served by Gulu Regional Referral Hospital. I want you to look at this, look where you are, and see how far you are from Gulu Regional Referral Hospital. And generally, what is the land size of the Acholi region? You will see it is very vast. And then what about the population? What about the population structure, terrain, the roads? And now from this you can plan to improve the health of our people. And in this context is the Acholi people. So in our planning, all the people of the region should have access. The key word here is access to quality health care. We are planning for universal health coverage, everybody to get access to health. And of course, we have to look at the priority diseases with the highest burden of morbidity, mortality, and disability. We have to mention disability. The road traffic accidents, if you're in a city like Gulu, you will give up. I'm sure even in Kitgum, there is a cadre of staff called border borders. They can cause any accident anytime. So morbidity, mortality, and disability. I think the previous presenters have given you the highest causes of morbidity, the highest causes of mortality, and admissions, and so on. And by implication, referral. But as I said, by next year, we are going to give you the figures of the type of disability or morbidity coming from each district, and how the number of referred cases, that is the vision we are looking at. And then, who are the most vulnerable groups we are looking at? And it is always women and children. Although in gender-based violence, you find it is women now clobbering some of us. So it is the vulnerable groups are the women, the children, and in those days, it was the IDPs, the internal displaced peoples in the camps. But now we have the refugee communities. So you can replace the IDPs with refugee communities. But there is no problem, you can leave it. Quality care is that care which is prescribed by standards and guidelines. There are standards of what quality is. I'm not going to go into all that. Prescribed by standards and guidelines. And we shall demand the Ministry of Health to provide us with those. And we have to provide quality care. We have to have qualified staff with appropriate skills. If we don't have qualified staff, we shall also lack the skills and therefore we cannot provide appropriate quality care. Attitude matters, and there are a lot of factors which play to providing good attitude by the health workers. And at the end, we are providing these services for the patient. Is the client satisfied? That is very important. You had our honorable members, the politicians were talking, and they were talking the truth. Are the patients, the clients satisfied? We have to endeavor to make our clients satisfied, leave them satisfied as they go home, even if they get nothing. And this demands a lot of effort. In summary, quality care is doing the right thing, the right way, timely, leaving the client satisfied. In the context of this presentation, let's take the stakeholders in improving health of the people. As the regional referral hospital, which has been mandated by the Minister of Health to take the lead in providing referral and quality care. We have the PNFP hospitals. Here in Gulal, we have Lacho Hospital, which is in very good partnership with Gulu Regional Referral Hospital. It is fortunate that I'm in the two boards, and we could see the good working relationship between the two. Then we have, of course, the private for-profit. I was a bit disappointed with the commissioner who has decided not to be around today, that the Ministry of Health has no control over the private for-profit, therefore they can do anything to patients. I think that has to be discussed. I don't think, since you have the knowledge and the facility, you should overcharge or retain a body for lack of payment. I think this is going a bit too far. I don't know. It's up to us to discuss. And of course, the health development partners, we really enjoy a lot of good working relationship with you. And of course, the district health office, the lower health facilities, the communities. Communities are very important in determining our health and improving the health of the people. The households, what do you do at home? And of course, individuals. There are individuals who have even forgotten that they are human beings. They don't bathe, they don't brush their teeth, they don't. This is, I think we should go back to those basics. In the household, I'm now in the village, you find people, one house, there are over 8 people, they have no latrine. They just feel free. When you go to visit them and you ask for where you can go, they say, feel free. And I think this is unacceptable. Some of these are institutional tools to improve quality of care in a regional referral hospital. We can add more. I told you my presentation is a stimulus. We have the regional blood bank. The cry now that there is lack of blood, doing cesarean section in health center 4 is a big problem. There you are. The regional blood bank, I used to see them driving all over the place. How do we improve that? The regional equipment maintenance workshop, the regional immunization supervision, that is to improve immunization. I listened yesterday, immunization has dropped. We have to have regional integrated support supervision support supervision is very important in providing quality health care. And of course, we have this beautiful thing called the Regional Health Assembly. Let's give it a blessing that this is not the last time we are going to meet to look at some of this. So the Regional Health Assembly, and my topic is the regional referral system. That was what I went through. What we went through with you was just introduction. Let's look at the regional referral system. Referral, we are going to define referral. But before you refer, is there a need to refer? You should really have an idea whether you cannot handle a patient. And what is the purpose of your referral? To send the patient to die elsewhere, or to improve the... I know facilities which refer so that the patient dies in your hands. Don't mention it outside here, but it occurs. Do we have resources available for referral? Do we have pre-referral treatment? Really, you have to, before you refer, treat that patient and give the notes. Send the patient with the notes. Do we communicate to the referral unit? That is very important. Communication from the referral point to the referee. It is very important. And do we follow up the patient we have referred? That is equally important. That is the feedback. So referral system simply is a mechanism to enable management of clients' health needs through resources beyond those available where they normally access care. If you are in a health center too, and the patient needs blood transfusion, probably you are not able to handle blood transfusion at that level. If it is intestinal obstruction, that is really resources you have is beyond you. You need to refer. And it is usually from the lower level care to the higher level care. But of course I know cases where even our health facilities refer patients to the traditional and complementary medicine practitioners. I'm sure one of us, even this morning, consulted. Those guys are very important. The traditional and complementary medicine practitioners. Even the staff, our staff go to, they go to those. But that is not really what we mean. And referral is an integral part of healthcare delivery system. It's mandatory. You cannot just do without referral. And it requires coordinated efforts by all partners. And referrals, the type I want us to discuss now, of course there are more, the commissioner mentioned others, foreign, whatever. For us, for our purpose, the routine referral that is non-emergency, where you want to get second opinion, that one is there. But our emphasis usually when we think of referral, it is the emergency where there is threat to life. So those are the two for the purpose of this presentation. The referral systems, the levels of referral system differs This is what I'm going to give you just for discussion. We talk of primary, secondary, tertiary, and stop there. We shall have to qualify what primary level is, from which level to which. Secondary also, from which level to which. Tertiary also. So we have a lot. I told you I'm leaving a lot of questions to be answered. The primary should be from the community level, the community health workers or VHTs. When they refer from the community to us. That is primary. Secondary is from the lowest health facility to where we have better services. This one is quaternary, is when the lower facility sends it to the district where there are specialized services. And when the district hospital refers it to the regional referral hospital, what do you call it? Quinary? You know English, me I have forgotten. But we can go on and on. What about when the regional referral hospital now sends it to Mulago, National Referral Hospital? But you can remember the debacle of Soroti National, Regional and Mulago, where the National Referral Hospital failed to do so. It is really also the attitude which is very important. This is just a guide. We can discuss this and agree on where, at what level. But the most important thing in referral is a timely referral. When you refer timely, it's a measure of the success in your system. When you refer too late, it is almost, as I told you earlier, you are referring death not to occur in your place. And the delays which take place, probably we delay in recognizing danger. And in our system, if you fail to recognize danger early, it's associated with staff, skills. Number two is, if referred, do you reach the appropriate facility timely? This is a very important aspect also. When you look at our systems, the physical infrastructure for referral, you might spend the whole day on the road trying to get transport. And then when you reach the referral facility, do you receive appropriate care promptly? These are the very important. From the referral point, the referee should recognize the danger early enough. And then there should be a system to take the patient to the next level of facility promptly. And on arrival, that's why earlier I told you, there must be communication between the point of referral and the referral unit. There must be communication, and you must have the note. And we lack some of those things. Those delays can cost life. Let's look at an effective functional referral system. If I may ask, I told you, this presentation raises more questions probably than answers. We could be able to answer in the next assembly. Do we have clinical guidelines and protocols and, and policy on referral system at every level? Do you have in your facility? DHOs, do you have in your facilities, in your office? Yes. If you have, praise the Lord. If you don't have, I think we should have clinical guidelines and protocols and policies on referrals so that we are familiar and we cannot make those mistakes I've been talking of. Do we have adequate workforce with appropriate skills to avoid those delays in referring promptly? And where the patient is going, are the staff there ready to receive the patient and handle at that high level? We looked at, I was discussing, as I told you, with my director of regional hospital, the staffing of Gulu Regional Referral Hospital is not adequate. It's about 70 there. Consultants are supposed to be 12. There are very many. There are 0. Senior consultants are supposed to be 4. We have 0. Medical officers, special grade, we are supposed to have 12. We have 5. And sister, continue praying for us so that we retain them. And let's pray that these positions are. So you can see this can affect performance. Not only referrals, all other specialized services. Do we have a functional health information system? Do we have sufficient commodities and supplies at every level of care? This is very important. It's very important. Pre-referral treatment at the point of referral is very important. As the patient travels along the way, cannot just go without. So we need those commodities. And at the end, we need all of us to join hands and talk about referral. That's why I'm saying probably next year, Lacho, Gulu Regional, the districts can tell us what they have done between themselves. And that is very important. We need appropriate health infrastructure, including transport. Infrastructure, the other day I picked courage. I prayed like Sister prayed. I had to pray to get a jab for this COVID thing because the misinformation and disinformation discouraged me. I thought I would just die. So I went and got a jab. While I was waiting, I looked at pathology unit of Gulu Regional Referral Hospital. Now I was thinking, if I die, this is where they are going to take me. Are they able to do a post-mortem and get those clots? Then are they able to preserve my body so that my relatives and people who want to inherit a few things will find me in a reasonable position? I was looking at all those. That is the final diagnosis, the last place of respect. We need the pathology unit to be, when we refer dead bodies to the military hospital. It's not very comfortable. I have not joined the army, so I want to. So those are some of the things. And we have to have the tools to track patients throughout. I raised this yesterday. I'm raising it now. For an effective functional referral system, we must have adequate financing to the health sector, the whole of the health sector. You remember I asked a question, and Chair, I think somebody, Commissioner dodged it. Probably you will answer it today. Since the Abuja declaration, we have been getting less than the 15% of the national budget. I don't know when you will receive it, at least 15%. And how is this money apportioned for clinical care, for the blood banks? How does it trickle down to primary health care? Let's look at land transport for referral. I think that is where we can really, that is our masterpiece. Of course, Ministry of Health, courtesy of Ministry of Health, UNICEF and WHO, they took some of us to look at referral system outside Uganda. And you find, as you were arriving in a hospital, I saw what was landing on top of the hospital was a helicopter, helipad. Patient had been referred 400 miles away. Our system is land. Walking, patients walk. Patients walk, and that is, they walk to the nearest facility. That's why we undermine from lower facility to higher facility. The patient will walk to the nearest facility. You have seen patients being carried on stretchers. Or on the bed you sleep on. Don't be surprised you are carried on. Bicycles. With these borders now, bicycles. And then borders is the commonest transport now. We have taxis. Sometimes we use actually cars. That is in our system. You know, we don't only refer patients. We refer also specimens and so on. Sometimes we have special cars to send the specimens and receive. And of course, here our interest is the ambulance. Let's look at the ambulance. The ambulance is to ensure prompt response to injuries and other forms of emergencies, basically. Ministry of Health created the UNAS, Uganda National, Ambulance Services, 215. Then the NAS, the National whatever. Ambulance Services established. The current status is we have ambulances, but my source of information tells me 61% are owned by PNFP, private for-profit, NGOs, politicians. Politicians have come in a big way. That's why we wanted some of them to be here. And of course, Ministry of Health. I believe with this COVID, the number of ambulances supplied by Ministry of Health has gone up. But that is, and the ambulances travel by land. One thing I did not mention is the type of terrain, the roads we have. some of the roads where we come from are impossible. Even the four-wheel drive provided by our partners get stuck. The ambulance, let's look at the challenges of ambulance next. Chair, how many minutes do I have? I'm about to finish.
I believe you can go on, just maybe rush through.
Yeah,
You know, it is rude to interrupt a keynote address.
yeah, they put it wrongly, keynote. So I'm here very proud that it is a keynote. The ambulance, most of them are urban-based. Urban. You go rural, there is nothing. The majority, you are lucky you have not entered some of these ambulances. They don't meet the basic requirements. No safety equipment. There is no monitoring. There is no ambulance crew. There is no communication. Receiving point when they reach even Gulu Hospital here. There's not, what we have to tell you is we don't have enough land to clear for receiving emergencies. I told you there are helipad and so on. And then documentation. And as I told you, national. Okay, let me hurry. She's just polite. She's telling me I'm slow. Next. Those are the lower level infrastructure. That one should refer to the next one. Those are the types. And staff, where I talked to you about motivation, they should have accommodation, decent, not very expensive, but decent. And this is the rural system. Next. I'm about to finish. When you go to the health facilities, if you get a bed like that, I think you are, what type of bed is that? For you, you know. Huh? Is it for delivery? Is it for what? Anyway, you know better. So, we need some of this basic equipment in our facilities. Next. I'm now hurrying. The primary healthcare interventions, you can see the overcrowding. And definitely, we need to refer. The OPT attendance is fantastic in the lower units because we have a lot of communicable diseases which we should plan to get rid of. Antenatal attendance, pregnancy, I reserve my comments about fertility, but there you can see the women are pregnant, and you can see a beautiful bouncing baby. Deliveries, most of the deliveries now occur in our facilities, but you find in a year about 32 mothers die. Maternal mortality is still high. Perinatal mortality, those are the highest cases of mortalities. Next. For the higher level of infrastructure, we need for a referral system. I told you the road traffic accidents are impossible now. I talked to my director. He says they have an orthopedic unit. We have the equipment. We need the department of dental department, road traffic accidents, the eye department, mental health department, diagnostic. The laboratory definitely advances in medicine has overtaken Ministry of Health. We have not been able to get some of the latest equipment. We are happy we are getting a cancer unit. although it is not directly attached to us. Pathology department is what I've been talking about for research and of course final respect. And the last one is very important, the IT department. Challenges. Knowledge among our community, they take a long time to accept referral. They believe in traditional and complementary medicine. Even when our community health workers tell them this is this, they would go to the Ajuaka, what do you call them? The witch, they are not really witches. I think they are also, they do their part. People want to go there first. And of course, another resistance is self-referral. That is a very common. It's very common. And those who can afford will bypass the nearest facility and just come. The communication barrier I've talked of. I've talked of inadequate transport and communication. Infrastructure, I've already mentioned it. General shortage of motivated staff. I've already mentioned to you the motivated staff. How do we motivate staff? And this is why our honorable members of parliament should be here. They allocate money for themselves. They don't want to pay our consultants. So when they come here, they find the life is uncomfortable. In Mulago, where there are many, 60% of their time they are not even in Mulago. They are doing their own work. Poor coordination and feedback mechanism. Inadequate financing, that one will keep on coming. And poor management of resources. When we receive resources, let's manage them properly. That is why with this COVID, I'm happy that the Minister of Health are not here. But clients are complaining that, let me stop. Let's use this forum. Let's raise it again next year, if it is going to be there. But I looked at our implementing partners, some of those who funded this. When I said it should be there every year, next year also, they were smiling. From now to next year, let's see if the national budget for health can increase. Let's keep on knocking. Let's strengthen management and accountability. You know, when we receive funds and we account properly, you will get more. If we receive funds and we don't account for it, then that is the problem. Let's look at how to improve the health infrastructure, whether it be staff accommodation, whether it be a ward or theater, at whatever level. That one is very important, to recruit and retain all cadres of staff. We have to retain. We are recruiting, but they run away. Then we should be able to monitor the regional referral system. I believe if you give all the information to the director, next time this presentation will give you a lot of figures on referral. Don't you think I've finished? Don't you think I've finished? I think I've finished. That one is, that is nothing else but the monitoring I've been talking about of the referral system. That is nothing else but the review, the stakeholders meeting. Let's look at what has been happening and then grade ourselves. Let every district grade itself on referral and other aspects, immunization and so on, and we see how we are performing. Because the whole purpose, as I told you, is to improve, to provide quality health care to our people. And there are standards and guidelines, set standards and priorities. Now this is the district league table, the ranking performance from 2002 to 2017. Let's have a ranking of the performance of the regional referral hospitals, but it will include also the district. You can look at this in 2003 when this started. Gulu was number 45 on top there. In 2003 to 2008, Gulu was number 1. Those parameters. We were beating them like nobody's business. Number 1 in 2002 was Jinja district. Then that is how we have been performing. I heard yesterday from Yoweri that we are now number 40, 30 something. We should fight hard to reverse that trend. Let's work together with the partners. Let's work together with the PNFPs so that we provide quality care of services. That is my presentation on referral system.
Thank you so much. Let's give him a hand clap, please. That was a wonderful overview of the referral system as he would love it to be. He gave us a background of Acholi region, gave us components of quality of care, the stakeholders in the health sector, steps in the referral system from the referral point to receiving facility and the need for communication. He gave us the levels of referral and the delays therein. He reiterated the fact that timely access is important for our success in the referral system. He stressed the critical components for an effective functional referral system, gave us the various modes of land transport, but focused on the ambulance, highlighted the need for the right infrastructure, and concluded with recommendations on the noted challenges. Thank you very much, Dr. Onek. We now come to the end of this session, and I hand over to the MC. Thank you so much.
Thank you, ladies and gentlemen. A round of applause for Dr. Onek and the session chair, Dr. Janet Ola. Thank you very much. Like I said, looking at our program, time management is okay for me today. And the feed has also been going through to the other room, the ballroom as well. So those of us who feel we are not, if spaces is still around, then that's okay. But if you could sit the other side, it's still fine, because the feed from this plenary side can go over to the other side, okay? We are going to break off now into our break room sessions. We shall have the elephant presentations here, and then the ballroom presentations on the other side. And the chairpersons, Dr. Dennis Ochula, for this hall, you'll take your seat, and Dr. Linus Amandu, for the other hall, please, you'll take your seats there. Our time for presentation is still 15 minutes, and for both presenters, and then you allow about 30 minutes, and then we shall break off for break tea. But ladies and gentlemen, before we leave, allow me to tell you that amongst us here in our midst, we have His Highness, the Paramount Chief of Acholi. Some of you are looking for a lot of regalia and so on. and so on. No. He is represented here by Ruot Collins Atiku, the Ruot of Patero Collins. And he's going to be with us throughout today. Ruot is here, and he's going to be our final person to close our session. So he said he wanted to take time to listen to what our presentations are like. So, Ruot, for a barricade. always I say, Gulu City is in his chiefdom. So this is the right person to have. Thank you, Rod, for coming. Attack. Ladies, let us break off. Like I said, chairpersons, 15 minutes presentation, 30 minutes discussion. Let us break off, and then we come for break tea at that point, okay? People are not moving. Yes, I'm also reminded that we have Dr. John Baptist. Where's Dr. John Baptist? The commissioner, yes. My eyes were going across. The commissioner for emergency services. Doctor, you're welcome. Thank you for being with us. For your part, you just start by signing our board straight. Your colleagues were here. So don't even, where is the ladies behind? Bring the sanitizer, please. For your party, just your colleagues have been signing. Can we get the sanitizer for this bit? Wrote at some point you'll sign the board as well. Yes. There's one here. There's one here. Is that good? Okay, good. Thank you. Session chair, please start.
Thank you very much, the moderator, for the opportunity. Kindly, I request that we settle and we start. May I take this opportunity to invite our first presenter, Mr. Lohum Bishop Janani. You're most welcome. You have 15 minutes, but as we all noted, our keynote speaker took a little more time than we had indicated, so we are going to compensate from you. Instead of 15 minutes, we shall divide that by half. So do your best. Thank you.
Thank you, moderator. My presentation is on COVID-19 update.
IT, please, we are waiting.
I will. Okay, for those who don't know me, I am Lohum Bishop Janani, Head of Community Health Department, Gulu Regional Referral Hospital. Currently, the focal point person for integrated disease surveillance, EPI, in Gulu region. Next, Gulu region, COVID-19 update from May 2020 to 21st September. When you look at the test conducted from 2020,
Kindly, Bishop, for purposes of our online viewers and followers, you are advised to remove your mask so that it's a little clearer. Thank you.
test conducted is 100,793 tests. Out of those tests, currently people that are on isolation and treatment center, those on treatment center are 29. That is for both Gulu Regional Referral and Acholi Hospital. Those on home-based care are 699. The new cases that were tested 2 days ago are 103. Accumulated total number of COVID-19 patients are 8,100 and my eyes is. Can you enlarge the total number of cases reported are 8,160. Total those on oxygen therapy are 15. And our positivity rate, the total number of people tested, is at 2.9% as of yesterday, but one. Where are these hotspots? The hotspots district are Gulu City, Agago, Noya, and Omoro. Sorry for the technical inconvenience.
The next time we shall also invite Omeme to join us in the review.
Moderator, will you still consider the 7 minutes?
We shall give you more time, especially on that slide. Especially on that slide. We are not going to hurry you. This is a very, very important slide. You remember what transpired on TV last evening as far as COVID-19 is concerned.
Yeah.
Thank you.
The total number of doses of vaccine, people vaccinated in the region is 38,288. That is the whole. If you subtract, you will get the second dose given 9,267. When you moved, we have, I talk about the hotspot districts. That is Agago, Gulu City, Pade. I omitted, I did not put Lamour Noya rather, as one of the odd spot district. The cumulated recovery from the treatment center is 1,325 to date. The total number of deaths that occur in this different treatment center and community, excuse me, scroll the other side, up, you move down. We have at 163 deaths. Out of this, we have 144 facility deaths. That is the 2 CTU, Lacho and Gulu Regional Referral. And community deaths are 19, although this would be more than that, but those are that are reported. Next. Next slide. Gulu region EP curve, the epidemiological curve. You realize our index case came, the first positive of COVID-19 was received in Gulu Regional Referral on the 2nd of May 2020. And we had a peak of more than so many cases that were all truck drivers. It moves on, and we had a cluster of infection. The first cluster of infection we had on the 33 weeks, that is prison, Amoro prison, that we had a cluster and we moved them to Gulu main prison. We also had a cluster in Pade, that is in the hydropower project, on the week of 35 of 2020. Then we had a total decrease, and there was an internet shutdown on the week 55, 53, and all that. So we could not get data by then during that odd campaign. We have been having low alert and testing. The reasons are many: the test kits, the PCR reagent, and also there was low alert on the week of, that is in 2021, during week 1 up to week 15. We had a second wave from week 19 that from May, and we had a peak of over 8,000 cases in the second wave. And most of these deaths also occurred in the second wave in all the treatment center in both Lacho Hospital and Gulu Regional Referral Hospital. Next slide. Regional map highlighting case burden, emerging clusters from week of 22nd to 4th to 4th September this year. We have estimated test target per district within every 2 weeks, and that is the result. You realized certain districts surpassed the testing target, notably Omoro and Amuro. The one of Amuro comes about as a result of the border point. Most of these clients tested are not resident of Amuro. Majority are travelers and truck drivers. But we need to appreciate Omoro because of the commitment that they will maybe tell us their best practice, why their team are surpassing the target. Next slide. Before next slide, go back. What are these drivers? Enlarge the slide. The drivers for these emergency clusters. we are all aware that there is a total laxity in observing the SOPs, standard operating procedures. As a result of not observing this, all the trading centers, we have illegal open bars and market, and people are not following any of this. And when you interact with community, the only communication, there is no COVID. These are politics and all that. When you go to funeral and marriages, the directives were all not being followed, and all this laxity of all the stakeholders. We are not pointing fingers. Then public transport, there is no SOPs being followed. Next slide.
Minutes to go, sir.
Test versus case per district. You can see for yourself. It also point those cases with hotspot. Next slide. Vaccination per district. This data is as for the first supply of vaccine, second and third. The fourth one, we could not run it because the activity is still ongoing and there is challenge of uploading data into the system. But at least we had a total, out of the 3 supplies of doses from Means of Health, at least more than 3 districts got 100% of vaccination, followed by 93 more districts, and the last are those districts that are really not performing well as per the vaccination status. And all these other vaccine received, we have not yet run. Next slide. Yeah. Go back and enlarge. Enlarge the slide. Scroll down. Let's go to the percentage. Yeah, we have district with 78%, 87%, and 83%. And those districts, you scroll where the sites of the district are. Of course, there are districts like Amuro, Agago are below 100%. What about the backload? We have a number of backload of data entry because of challenge of either the internet, and also we have a total shutdown at Ministry of Health. Data is not being entered right now. So we need to really work on that to ensure the actual report reflects what is on the ground. Because even what was mentioned yesterday and yesterday but one about the backload of vaccine in the different districts, that is not true. Because most of the districts are about even to complete. Like Gulu have already completed the vaccination of the doses given. Lamour is left with around 130 doses, which they are completing today. Amuro, we retrieved some of the doses, and almost all these districts have completed the vaccination, but we need to really do due diligence. Next. Gulu region, COVID-19 achievement. What have we done in the area of coordination? There is we have functional district task force team in all the districts, and they offer statistic and guidance to the pandemic to control any of the intervention that needs to be put. Participants in the region were trained as the regional response team, and IP meetings for strategic direction of interventions are ongoing. Under surveillance and contact tracing, we supported the surveillance focal person and labs team to report alert, conduct contact tracing at community level, and also do referral for home-based care and those that are meant to be in the treatment center. IPC, Infection Prevention and Control, and home-based care package. We oriented health workers and village health team to conduct their activity. Next slide. Lab service. There was a TOT on biosafety, also RDT testing for COVID-19 in all the districts. We have a functional app system to transport all samples and use of biometric access control placement in Gulu Regional Referral Hospital. Under case management and home-based care, Gulu Regional Referral Hospital and Lacho, CTU and home-based care, they have a portion where each facility should handle in terms of home-based care. Under social behavioral communication, there is a mass media campaign on COVID-19 prevention that we have to appreciate the airtime from the RDCs of the different districts and also the different radio stations offering airtime for us to continue really sensitizing the community in regards to prevention approach. Next slide. We have a number of challenges, but all this I can summarize. There is problem of reporting. There is also problem of kits for the home-based care team. The best practice, we have districts that are really uploading the situation report in ODK. Among them are Omoro district. And we also upload Omoro for creating a temporary holding center to stabilize the evacuation of these patients. We also have to appreciate our IPs for procuring us 1,000 pulse oximeter, which is yet to be distributed to VAT to help in monitoring the home-based care patient. Challenges of evacuation, we have, most districts do not have ambulance for timely evacuation of this patient. We have also tendency of patient refusing to go to CTU. People refuse. There is stigma in the community, which is really real. Few health workers are complying with the mandatory testing of after every 2 weeks, such that we comply. And we have inadequate home-based care support to cover all villages. And also we need to functionalize the village task force. Scroll. Recommendation, partners to government to include Lacho Hospital to get the allowance, the risk allowance of COVID-19, because they are not really included in that, because in a way there is partnership happening and we need really to embrace what they are also doing. Thank you for listening.
Thank you, Bishop. Thank you very much. We gave you more time. You exceeded your time by about 3 minutes. We did that deliberately, aware of what is around COVID-19. The resident district commissioners are here. Our dear chief administrative officers are here. The DHOs are here. This is the best opportunity for us to discuss and see how best to mobilize people for the vaccination. Thank you. Thank you very much, Bishop. May I take this opportunity to immediately invite our next presenter, Dr. Kumakech Jimmy. Doctor, you're most welcome. Come to share with us the status of TB, leprosy in the sub-region. Thank you very much. We give you 10 minutes at most to do that.
Thank you, Session Chair. My dear participants, protocol observed in the interest of time. Session Chair, I want to start by saying that TB has suffered a lot in terms of resource allocations. And most of what we are going to navigate around will be around that. And I want to believe that is the same thing happening in this hall. That's why the giant TB is to be presented on 10 slides in 15 minutes. Okay? Yes. I'm called Dr. Kumakech Jimmy. I'm the regional TB and leprosy focal person for Acholi. It's no longer supervisor, it's focal person. I was guided to make my presentation under the following headings: introduction, methodology, progress in the programmatic areas, key indicators, achievements, challenges, lesson learned, recommendation, and then conclusion. I'll try to do my best because I'm a result-oriented individual. As far as introduction is concerned, you can see that TB, can we go back? Okay, TB is still a public health burden globally, okay? And then we have TB HIV co-infection. We call the dual TB HIV infection. Still remains a major challenge. We shall learn why. Then Uganda, remember Uganda had achieved its target, okay, for elimination of leprosy. But interestingly, we are getting re-emergence. Let's move. Can we move to the next slide? Yes, let's look at the progress in the programmatic areas. I couldn't pick all because there are very many, but one is case detection. Via case detection, we are still doing very bad as a region. We have improved. Generally, our indicators have improved, but for me, I've not reached a celebration because we still have a lot to do. We had gone as far as 60% versus 90%, but as I talk, we have dropped as far as 40% in the last 2 weeks. So that's very dangerous for the region. OPD screening. Our outpatient department screening should be 100%. As a region, we are at 72%. And that's very dangerous. But I want to applaud Uganda Prison Services. They have been above 83% all along. I think that has been so good. We could clap for them since we have the boss here. Yeah. And actually, what is affecting screening in Uganda Prison Services is the outpatients who are coming from out. I think we are missing from there, but for the inmates, it is perfectly done. I think bravo for that. The Minister of Health has circulated a document on a systematic TB screening. That's a letter from the Director General of Health Services, with the keen interest on improving that particular indicator because they discovered we are doing badly. I hope this document will be circulated broadly. To improve case detection, the minister has brought in what you call the active case finding, okay? Active case finding has been brought to 50 districts in the country, and we have been lucky to take 10%. Those are 5 districts. But I still feel we needed 100%, we needed 8%. We needed all the districts to be included because we are still doing badly. And then our region, as you know, has been declared a regional TB emergency. So meaning we are doing badly. We need to move far. More interventions have come in place after a number of meetings. We have intensified case finding TB stamps. Okay? Very soon, all the facilities are going to some have already received TB stamps because you have discovered there was a big gap in screening because the documentation seems to be a problem even in the tools, okay? People get mixed up in a way, especially the data team. So now we have stamps. So somebody screened the medical form or the book will be stamped to make it easier to capture. I hope it's going to improve our screening. And then the contact tracing should be key in that area. Another area, programmatic area, is partner engagement. These are significantly improved both at national and local level. I'm proud to tell you that we have over 6 partners now that are supporting us. We have right now Acholi, UPMB, TASO, then PACE under TASO, then IDI. I have a lot of interest in IDI because they are trying to help us by supporting the private for-profit facilities who had never been considered, okay? And for me, that is a plus because those people get a very high number of missed opportunities. Then let's go to TB prevention as another programmatic area. We have 3 TB preventive therapies, no longer isoniazid preventive therapy because now the new regimens have come in. We are still doing badly, but we are better off than many regions because we are at 43% against 60%. I think that's good for our region. But still for the under 5 contacts, we are doing badly. We are in 30%, which is not good. Then infection prevention and control. At facility level, we are still not doing well. We expect every facility to have infection control committee for TB. But I've traversed the region, I think we have less than 30%. But I'm very sure very soon we shall get where I want to go. And then in infection control still, we have contact tracing. I'm glad TASO is being backed up by PACE to do that work for us. How I wish they increase the scope of their work. Sputum handling is still poor. That's why sometimes our poor VHCs even end up getting infected. Simple things. We need Ziploc bags, but they are not there. Then another key area I want to talk about in the program is TB dot. Okay? We have community dot, we have facility dot, but the community dot is more of like a paper dot. Okay? Just because our sub-county health workers are not being supported to do that work. Facility dot is happening well, especially in DRTB. It is perfect. I give them applause there.
Your time left is 5 minutes, sir.
Thank you. Then a TB HIV collaboration. This is another important area that, most facilities are doing these activities in silos, which is wrong. Because TB and HIV are brothers and sisters. So we are bringing the issue of one-stop center. As I talk, Agulu Regional Referral has started. Mr. Director, I want to really give applause to you that all the HIV TB co-infection are being handled in the TB unit. And that is a plus. And that's how we should go as a region. Then another program area is the cross-border TB. We missed it there. Cross-border TB is a big issue due to our porous border, okay? The district of Amuru and Lamour, we have suffered a lot of TB and leprosy due to cross-border TB. So this needs to be strengthened. However, surveillance is being done, but we need to strengthen it. Then our key indicators are TB screening. I told you we are at 72, but we need to get to 100%. Our case detection rate is low. It is still at 53%. We need to get to 90%. Our treatment success rate is at 67%. We need to get to 90%. Our cure rate, we are between 60, for the last years, we have been moving between 60 and 65. We need to move to 80%, but we are doing well. 65 is good, okay? Then the number of patients newly diagnosed with TB. I told you we are in an emergency region, meaning that we are supposed to diagnose more. Then the turnaround time for TB diagnosis, big challenge. Sometimes 2 weeks. Imagine you have a DR patient, 2 weeks. I was disappointed during the catch-up campaign that the result for a DR patient came after 4 weeks. That's very dangerous. I don't want to mention the district. Then the number of leprosy cases being diagnosed with grade 2 disability to us is a very serious indicator. This means we are having very low index of suspicion for leprosy. And being a slow progressing disease, we don't know what will happen in the next few years in the region. And then the inputs and outputs of the various IPs. I've told you we have more IPs, but still I am not convinced about the input and outputs. Otherwise, we would have moved a little more away from this. Our reporting rate is doing well. We are at 82, that's good, but we need to go up to 100%. And the level of engagement of the community. TB is a community disease. And for us as a region, we feel that's a direction we have to follow. That direction is still not doing well. So we are trying to engage all the stakeholders to make sure our priority should be in the community engagement. Then our review meetings are very lacking. Our review meetings are supposed to be at facility level, district level, and regional level, but they are all lacking. Then the number of patients screened for both TB and HIV. It is alarming. One time I just went, I surprised some big district hospital. Reaching there, I found almost 40% of the people screened for TB were not screened for HIV. And that's, you are not completing the cascade. The cascade should be complete. That's very dangerous. And then the number of stakeholders meetings. Allow me to mention some key achievements that we got as a region.
Kindly do it in 1 minute now, sir.
I beg you to allow me to mention this because they are very important. This meeting is once in a year.
Yes, we have given you, sir, at 1 hour.
New TB diagnosis has increased, and that's good for us. TB screening has improved, but we say there's a gap still. Our treatment success rate has improved, but we need to work for a better one. Then the TB catch-up campaign, this was a wonderful exercise engaging the community in 4 days. And guess, we got over 200 TB cases. So this tells you the power of the community engagement in TB. The number of leprosy cases being diagnosed has increased, okay, due to support supervision. And then we have got a 16-module gene expert machine in Gulu Regional Referral Hospital after a year of struggle. And I think this has been good, though priority is being changed by some of the people handling the machine. It is more doing the work of HPV than what TB. All should be taken care of equally. And then the number of IPs I mentioned, that support supervision and mentorship has improved. To me, this is good. And Agago District Local Government emerged the most improved district in the country, not in the region. And to me, that is good. Could we clap for Agago? Yes. And next time, I want them to be the best district in the country in TB control. And then with the one-stop center model, I told you we have already started at Regional Referral Hospital. Key challenges. 1, TB and leprosy screening is still low. Treatment success rate is still low. We have irregular supply of TB and leprosy commodities. I was very disappointed yesterday when the NMS boss says they have been at 100% for the last 2 years. when I've been struggling for the last month with the district focal person to relocate up to when we could not relocate anymore drugs. I think we have to be factual. There is a challenge, the irregularity. We have to improve on that. DRTB, I remember in Kitgum, they did not have actually levofloxacin for some time. So something needs to be done there. Partner support still low. And then, but this is related to priority. What we have discovered is there is less priority for TB and leprosy, but more priority for other areas. And then inadequate meetings and stakeholder, meetings generally, then there is very low budget for TB at all levels. I'm glad we are representing all the sectors and the units in the country. At your LC3 level, which is the most functional unit as far as planning is concerned for the country, how much budget are you allocating for TB? Should it be zero? No, we have to do something there. And then our 50% of leprosy cases are being diagnosed with disability grade 2. This is very dangerous. TB HIV collaboration is still doing badly, but we have started. Then the late and non-synchronized reporting. Our data quality is very poor. When I was seeing the data here, I was bleeding in my heart, especially when it comes to TB. Because I find what I have, the review data is different from what is being presented. It's because of the lack of synchronization. How I wish the center could do something to that so that we are synchronized at all times. Then the ring fencing of TB and leprosy is a big issue affecting the quality of service there. You go to a facility, the only person handling TB and leprosy, one person, that's a focal person. I thought all of us are supposed to do the same work. And in most cases, it is a low cadre, the nursing assistants, we have to fight that as a region. We have started, but we shall reach somewhere. Then the community engagement is still very low. I told you this is actually the highest priority is community engagement if we are to reach somewhere. Treatment interruptions, still a big issue. And when you ask people why, they will tell you the first thing is, I don't have food to eat for your strong medication. So as partners, we should, and government should not look at giving the medicine alone, but is our medicine being taken? And if not, why? Food is number one. People say they are poor. And then the poor social support. Lack of transport for regional supervision. Imagine a whole regional supervisor does not have means of transport. And you expect me to monitor all the entire region. And you find fleets of cars for maybe only HIV. I think that is very unfair. When I raise this thing at high, somebody say, but regional referral has a lot of vehicles. Which vehicles? Regional referral may be having 3 vehicles, but how many programs run in a day? Okay? So I think we should not really play around this. And I've discovered also the district TB and leprosy supervisor for Lamour does not have TB supervision means of transport. It's used the one for facility. Meaning if they transfer him today, he will have nothing. Lamour will go to 0. Cross-border TB, still a challenge. And then referral of drug-resistant TB.
Thank you, Doctor. We have given you 5 extra time out of the 15,
okay.
And we may not proceed at this rate.
Okay.
Thank you. Thank you very much.
Thank you. Can I mention the lesson learned only?
Thank you. We'll proceed during interaction. We still have a whole session to discuss, please. Time. The moderator is there on my neck, standing right. Okay. Thank you. Thank you very much, Doctor.
Okay, thank you very much.
Let's put our hands
thank
together.
You for listening.
Thank you. Thank you. Thank you. Kindly, you'll come and take a seat here. Please, Doctor, come and sit this side. Bishop, we invite you here. We're going to have an interaction with the audience. I know we are late, but we shall do it in the next 15 minutes. Then we hand over to the next category. We shall start our discussion with COVID-19. Then we come to TB. That is not to say TB is that low. No. I know he's going to complain. As you also rest. Yeah, as you rest. Thank you very much. So it is now open to discussion. Bishop made presentation on our status as far as COVID-19 is concerned, the different areas, screening, the surveillance, logistics, vaccination, and others. I'm sure you are taking notes. This is the time for us to ask questions for clarifications, make comments, suggestions, recommendations on COVID-19 response. We shall take 5 hands. The first one. The second one will be Commissioner, Community Health. Thank you. The third one is our sister that side. Please, we may need to have 2 microphones that side, then we move. We shall give Ruot now to be the last of the 5. Thank you, Ruot, for your.
Thank you very much. My name is John Paul Onye. I'm representing the Chief Administrative Officer, Nwea District Local Government. I want to refer a little bit to the opening remarks by Dr. Paul Onek. As a layperson, we have been confused with what comes in the social media. I'm addressing the issue of the intake of vaccines. And I thought maybe it was because I don't know much about medicine. That is why I get confused. But when doctor himself said he was also confused and he was not going to take the vaccine, then I said, I think we are in trouble. We find ourselves in this situation. We want to campaign and have as much intake of the vaccines as possible, but there are people decampaigning the vaccines. You go to the health facilities, you take a count on the number of those who have taken the vaccines, there are very few also. So how are we going to address this problem? If the medical personnel themselves cannot take the vaccines because they also have doubts in them, what about us, the local population? This is a very serious concern, and I think if we don't get a means of addressing it, the fight is going to fail. My other concern is about data capture at border districts. Why don't we disaggregate and say this information we are picking is for a traveler, is not for a resident? Because if you see the data which is picked from border places like Amuro, for example, they overshoot certain numbers. When you go physically on the ground, you find there are very few people in Amuro who have taken the vaccines, who have gone to do tests. So I think this is a confusing thing which can be corrected by simply disaggregating data vis-a-vis this is a traveler, this is a resident. Let me give more time for other people. Thank you very much.
Thank you very much. I think Ministry of Health has everything it takes to disaggregate data, and the Resident District Commissioner of Amuro has been on record mobilizing his people to go for vaccines, aware that very few of them had gone. And I'm happy he's also in the house. Thank you. Commissioner, you're welcome.
Yeah, thank you very much, Chair, and my regards to everybody. I hope you can see me, or you're only seeing the head. Let me stand up because I'm also challenged in some way. Dr. Pinto George is my name. I'm going to focus on COVID-19, and I would love that God help us and continue bringing for us such epidemic time and again, because it awakens us up. And I want to believe that beyond COVID and after COVID, we shall have a very, very strong healthcare system in this country, something we have never thought about. We have expanded our bed capacities. We have trained our health workers. We have brought in new equipments we have never brought in before. The Commissioner for Ambulance was here, would have told you that we have received the biggest number of ambulance services in the country than ever before. But this is all because of COVID. I know COVID has its bad side, but every disease that comes must give us an opportunity to do better. The only thing we have not been doing best was not to prepare the community, and that will come in my presentation later on. But that said, I want to say that the recommendation we are giving and applauding Omoro and Amoro for doing very well in terms of testing rates, and not only testing rates, they are doing quite better in many aspects in terms of COVID response, not by accident. And I think Amoro in northern Uganda is a pilot district and is a model district for COVID interventions, looking at community empowerment and community engagement in that aspect. Yesterday, His Excellency the President was saying, if we want to open our economy, the best way to do is, again, go back and revitalize the village health teams, retrain them, give them the home-based care toolkit. And I think nobody even understood what that home-based care toolkit was. But if you allow me, I can embark on it and brief you what it is. We cannot do COVID in homes of people without those home-based care toolkits. And you all know that even when we talk about COVID treatment, care, and management, the 80% of everybody who has COVID gets their care from home. They even don't come to hospital. We have only failed to capture them in our home-based care registers. Just because many of you have tested positive for COVID in this room have never even gone to say, I am positive, I want to enter into your home-based care inventory or even the register. And so the village COVID task forces don't have the opportunity to capture you and put you there. The only people who access our facilities, whether it is the ICU, whether it is the facility-based care for COVID, are only 20%. And that means we are only struggling to put too much resources to look after very few people. So Amoro was chosen in northern Uganda to be a model district. And now if you hear that every district in this country was given 150 million, every city in this country was given 100 million. Every village COVID task force was given 400,000 for this quarter. It was out of what came out of the Amoro experience, Amoro being one of the 4 districts in the country. When we talk about the 4 initial districts, we're talking about Amoro, Busia, Mukono, and Ngora, to pilot and see, can COVID be managed at home for those ones who get infected and are positive but don't have symptoms. And now for us, if you don't have symptoms, then you are not sick. Just like if you have malaria parasite in your body, you are not sick. So you can be looked after from your home. You can be monitored from your home. You can be taken care of if you have very good referral systems and mechanisms. And that's why we are saying now it's time for us to give what is necessary for these people, whom we call the community health care workers, to look after these people within the confines of their homes. I don't have the luxury of time to tell you what are in those home-based care toolkits. I will discuss that when I make my presentation. I submit. Thank you. Over to you.
Thank you very much, Commissioner, for that. We shall get from the rapporteurs and add your submission as an addendum to Bishop's presentation. Thank you very much.
Thank you, Chair. My name is Margaret Mugisa. I work with Amref Health Africa. Bishop, thank you for that detailed presentation. My concern is on functionalization of village task forces. Like the previous speaker said it all, I think we need to put our energies in our villages. We need to understand from those who are performing well how they made these village task forces functional. Because for us who interact with people where we work, you get calls, they are asking, they don't know what to do. Even the village health team members, our dear VHTs, up to now, they are still confused. One, they don't know that vaccines have come. They are still wondering whether it is only teachers to be vaccinated. No, that was for only teachers. So there is knowledge gap. We need to empower these village task forces. And the question is, this goes to all of us because we are stakeholders. How do we functionalize these village task forces? Because we know in this fight, they'll help us a lot to fight COVID. Thank you.
Thank you very much. We shall take one more, then we go to the Detroit, the Resident District Commissioner of Lamour. Surely I can't deny you that chance, otherwise I will not go back to Lamour.
I did it stubbornly to check on that. Members, I think we needed more time on these COVID things because everything looks like we are trying. We are trying the village team. We are trying every corner to see that where do we going to succeed from this. I think, Bishop, you talked about the hot spot. There should have been, you should have guided us that hot spot in this district, the cause of hot spot is this. So that when we go back as other districts, we shall also see that this is what is bringing us problem. How do we close that tap? So that at least we continue, because if you give us a blanket hotspot, you count the district, and they might even be here. They don't know the intelligence that you have got the report from and which area specific, so that now we can concentrate. We can concentrate on which sub-county, we can concentrate on which village, and how, where do we put in the resource. You know, the resources, we have very little resource for this COVID. So where do we put in this resource to vis-a-vis what we are trying to do? And TV, the focal person for TV, I think we needed more discussion with you and our team. You know, we have a lot of challenge at the border of screening. So we need more of a resource, more of the point. As we have done with the COVID, I think we need also to focus the same method that we have been using of screening people, getting in and out from our border through that. You know, we have a big challenge with our neighbor. When you have a stubborn neighbor, you don't sleep. So we are in that category. So we need to share a lot and see how do we handle that. These are the two concerns. And finally, what I've been saying about this money of COVID-19. The people, the population have not understood. The government, we need to share more on that, because the people are thinking this money should have gone to household, because all of them are being handled by COVID-19. They are not working, and they say now if the money comes in the district, it must go to those villages, to everybody. And they term that we are eating their money. They don't know that there are people who are working for others so that these are done. So these are the areas that I wanted to share. Thank you.
Thank you very much. I have been told we have only 5 minutes to conclude. We still have 2 hands. I can see the Resident District Commissioner of Agago, UNFPA, before we go to road. Okay, let's agree that we shall pick the 4, UNFPA, Cinderella, our colleagues. That's Amor, I think. Yes, the resident district commissioner Amor. Then we come to Agago, and the Detroit will conclude on that. Thank you.
Thank you, ladies and gentlemen. I want to applaud Dr. Lima and the team, more especially my brother Bishop, who have always been with us. You know, without Gulu Regional Referral Hospital, for us Amoro would be doomed. But Dr. Lima, you should always remain strong because I'm praying for you. You know, for me, I rarely pray. But when I do it, it's always real. Amoro, we have one great challenge, which I want us to discuss about it. The border aspect and the local community. You heard my brother Bishop saying it here. Most of the intervention is always put at the border. And now the community, you see even the help which is given. The ambulance we have is for border point. The Ministry of Health talk about ambulances, but it's stationed at the border point, not for the community. So we need to think through when we are talking about COVID in the area, because now the village health team, we trained over 1,000. But when you talk about the money needed for them, you see the little something given to them. So when let's try to differentiate the two, because the team we have is the same team doing the work at the border point. So we need to try to help Amoro more, because Gulu Regional Referral Hospital did their part to ensure that we stop what was coming from South Sudan at the border. But now the local community, you hear cases in Lakang, needs to be transported to Gulu Regional Referral Hospital. We don't have ambulances. So these are things we need to help. I know I've been crying to Dr. Lima to help, but sometimes their hands is even tight. There's a day I got teams going that they are going to grab him because he has not paid for the feeding. But we were taking people there to eat. There were no resources even allocated to Gulu Regional Referral Hospital. You see other referral hospitals which were having no cases, but they were getting the same funding. So these are things we need to think through together. But I want to thank the team at Gulu Regional Referral Hospital. Thank you very much.
Thank you very much, our resident district commissioner of Amoro. And also thank you for always standing with us in the fight. We hear a lot coming from that side. Thank you. Let's have UNFPA, then we go to the resident district commissioner of Agago, and finally, Detroit will make his contribution on this. 1 minute, please.
Yeah,
Thank you.
Thank you, Dr. Acholi and our panelists. I just wanted to make an important point that we've seen, especially at the time when we had lockdown, we had notable challenges with stockouts of family planning, commodities, and other essential supplies. And we know that with the threat of either third wave or subsequent issues, we must make an action here in this meeting as we go back, that we have actions in place to make sure that we have enough supplies of essential commodities in place, take advantage of some of the support that our partners, especially UNFPA, has in ensuring continuity of service delivery. But also the other component, I like what you're doing, Dr. Acholi and the team in Lamour, and also Kitgum. I want to applaud the Kitgum team that SOPs compliance is really strong, but if you come to Gulu town and move, it's like we're living our own lives. And I thought Gulu being an epicenter and a hotspot, something has to be done. We can learn from what you're doing, from what Kitgum is doing, and even the other districts, so that we are all uniformly enforcing the presidential directives. Thank you.
Thank you very much, Cinderella. Let's move to the resident district commissioner of Agago. Somebody support her with the mic.
Thank you so much, Chair. I want to make a comment on the village task force, especially the VHTs. They were trained, but they don't have the toolkits. There's even no standard reporting format for them. They are willing to work, but there are limitations. I want to talk more on Omoro because I've just gone to Agago. They would call and tell me, Mego, there's a client here in home-based care, but I can't get there. No PPEs. And as a human being, you would look at it as it's impossible. You can't tell someone to go to attend to a COVID-19 client just like that. You would be promoting the spread of COVID-19. So these are issues that we need to address so that they're effective and they would help us. Even community mobilization, you would need PPEs. You can't go mobilizing people just like that. So they also fear. So if we cover that gap, it will be very, very effective. And then we had talked of good practices in Omoro. One, we would work as a team and support each other. There was a very good working relationship with our health workers, and we would hold regular stakeholders meetings, especially with our sub-county key stakeholders and the health workers, at times to counsel and encourage them to work despite the challenges. And above all, we would treat everyone as a whole person. When I talk of a whole person, we look at other responsibilities you have. You might look at one as your DHO, but someone is saying, my husband, my father, my son, my grandson. So when there's a challenge in one of those responsibilities, you can't perform well at workplaces. So we will go to monitor, we need to take up this. It's not about intimidation, but understand the problem of someone and you would achieve what you want. So that's how we've been working in Omoro. And we had also agreed that enforcement is not beating. So our forces would go with the risk communication team to communicate to the community about COVID-19. And we were not beating them. So they would take up our messages, though they are stubborn people, but we would try our best to see that they listen. Thank you.
Thank you very much, Madam RDC, for that submission. I was making consultation. You know, we are going to hear submission from Rod. I was making consultation on how we should do that. Is it in Luo or in English? But I've been advised that he's a participant now in this discussion, so he can freely speak to us in English. So I'm honored to have this opportunity given to Ladit Roth to make contribution on the topic at hand and will be the final contributor on this matter. Ladit Roth Wajoli, for you.
Good morning. I think we all know that the campaign and the myths associated with vaccination is very high, very loud, let me say like that. And it's drowning out the efforts being done by the health services to increase the vaccination rate. Now my question is, in the first place, what strategies are being put in place to counter the campaigns and this kind of thing? I mean aggressive strategies. I would suggest one thing, that we have people who have already been vaccinated in Uganda and all over the parts of the world. For example, in America, over 250 million people have been vaccinated. Why don't we use the testimonies and data from these vaccinated, post-vaccination people campaign aggressively to encounter these myths and the campaigns, because otherwise we are not going to succeed. We'll only be making incremental progress, little. But I think if we use testimonies and data and people who have already been vaccinated to speak out, it will resonate more than if we just, technical people can tell, oh, you need to get vaccinated. That is just, to me, is not going to be successful enough. But if you hear a friend saying, I've been vaccinated, I'm healthy, because the issue of blood clots and also your magnets sticking on you, and which are actually not true, but they're allowed in the communities. I'm talking from the community's point of view as a cultural leader. So I think we need to map up a new strategy to work on this. And I think testimonies and data that has been done to counter, to challenge those things that which are coming, the negative images that are being brought forward. If you ask them, in America, 250 million people, how many people have been sick? You ask this kind of question. In Uganda, many people have been vaccinated. Are they sick? Is there anything wrong with them? Of course not. Thank you.
Thank you. Thank you. For your material, this road, for your material. Bishop, there were some few questions, not many. If you could respond to them in 2 minutes.
Thank you. I want to start with the RDC Lamour. The hotspots in this district are marketplaces like Gulu City. Gulu main market, move right now. You'll see nobody is putting on masks. If they are there, then it's less than 10%. Washing hand at the gate is not there. And all the market within Gulu City. And there is eat out, which is purported as bars, are there 24/7. Noya trading centers that attracts most are in Alero sub-county, Poron sub-county. So for the benefit of time, I could not mention all this. Then all funeral sites and wedding sites. At the end of the day, people can do, but emotionally, you will find people are almost not following social distancing and even putting on masks. Odek, Omoro district, we have Odek, Lakwana, and Palaya along the highway. So I could not make mention of all those. We need to functionalize village task force. It is the means of government to see what kind of strategy and to assign partners in the different districts to see that the VATs are doing their work and also providing the test kits, the kits, the VAT kits for monitoring. I think that would go a long way in really motivating the VAT doing their work. I must say, with support from WHO through AMREF, VAT were trained, and also the VAT registers were distributed. Because there was this question of VAT registers. VAT have registers, and they need to make use of that. But also we need to dig more. Why are they not really doing that? That is the issue. Issue of vaccination, our chief has already really hinted on. I think the strategy we need to do is to bring all these religious leaders, the cultural leaders, and all these people, elected leaders, to do more of sensitization for community to understand. I remember yesterday, His Excellency was saying, I am among the number vaccinated. So if we can continue to drum that, it will go a long way of really dispelling all these myths around. Most of these other concerns were strategy, not question to me. Thank you.
Thank you very much, Bishop, for that. It is true, as health workers, we need to show support, and we do support. As for me, Omoya Dennis Ochula, the acting DHO of Lamore. I was one of the first to be vaccinated in Acholi sub-region. My vaccine was on the 15th of March, 2021. The second dose I got on the 27th of May, 2021. And I have never even had any one day off duty. I have been okay throughout. And Michael has been checking on me every week, and I'm okay. He also vaccinated himself. He has been okay. The RDC is here, vaccinated, is okay. The LC5 equally. So the vaccine works, and it is good. I want to thank you very much for being a good audience. I want to thank our presenters. May we put our hands together for them, please? Thank you. I now retire them. I also retire myself and hand over the audience to the moderator. Back to you, sir.
Thank you. Thank you very much, Dr. Dennis. Thank you. Ladies and gentlemen, a round of applause for yourselves, please. On my part, everything is still on time. And I need to thank the chair for that. Thank you, Chairman. Thank you very much. And your team, Bishop and Dr. Kumakech. If it is about vaccination, I've also been vaccinated. Both doses, and very early for that matter, I remember. So, can we please retire? It's just slightly after 11 o'clock. Can we just have our break tea for about 30 minutes, please? If we could just be back here just about 11:30 or so, because the next round of presentations, we have 4 presentations before lunch. And the chairperson in this hall, Dr. Dithan, please, you'll need to control the timing. Are the presenters around? Yes, let me take a quick one. Dr. Lima is here, I know. Patrick Okello is here. Dr. Patrick, Commissioner. He could be in the other room. Dr. Tony Tumesije, here with us. Yes, and Mabel Naiveri. Mabel from USAID. It will take us, during tea we shall get to her, so that we shall know. So, Dr. James Lima, you will be the first at exactly 11:30. So, Chair, ladies and gentlemen, let's go for breakfast. And when we return, we come straight to our break room sessions. I am informed Mabel will present virtually, Chair. So we shall log her in. Okay. Please maintain the 15 minutes. So at 11:30, Chair, we are starting. One. Our session chair is ready, Dr. Dithan Chiraga, the Chief of Party for Rights, North Acholi. Chair, can you bring the mobile microphone, please? Where is the microphone? The presenters are here. Chair, please, take over. 15 minutes strictly, maintain time, 15 minutes strictly, and 30 minutes discussion, so that we're out of here. Chair, I'll be looking at you from outside. Okay?
Yes. Yes. Hello. Good afternoon, everybody, everyone. Welcome back from the break. Once again, my name is Dithan Chiraga. I work as Chief of Party Rice North Acholi, and we are proud to be associated with this first regional assembly organized by the Gulu Regional Referral Hospital and the different partners. So we are tight on time, and we have 4 distinguished panelists. 3 are seated here in front of us. The 4th panelist, I'm told she's going to be online. And we'll be strict on time as indicated so that we can have our lunch break on time and then be able to come back in the afternoon to finish up the sessions. So the sessions that we're going to have, I'm hoping you have your schedules with you. The first one, we are going to listen to performance of regional medical equipment maintenance from our Director, Gulu Regional Referral Hospital, Dr. James. That will be quickly followed by performance management, the dilemma of enhancing the productivity of HR. And we are privileged to have Dr. Patrick Okelo, who is the Commissioner for Human Resource Management at the Ministry of Health. Then we'll have a presentation from the local service delivery activity led by UPMB, and this will be done by Dr. Hilala Rima, who is the Deputy Chief of Party. He will introduce the topic to us. And then finally, we'll have Mabel from the Social Behavior Change activity to talk to us about engaging stakeholders to advance social behavior change interventions in communities using the SPCA's Experience Lab. So I'll be timing, and I'll let you know when you are just about 5 minutes to the end of your presentation. So we'll keep it brief, and after the presentations, we'll have discussions and recommendations. So James, please, you can either present from there or move to the podium. Thank you.
Good morning, ladies and gentlemen. In all your capacities, I'm presenting the performance of regional medical equipment. And in this performance, I'm going to divide it into 2. One is the workshop itself. We usually call it a workshop. And then the other one is the desired people who do this work, right from the top to the foot soldier. My name is James Selima, the Hospital Director for Gulu Regional Referral Hospital. Next. Ministry of Health set up this performance, set up this medical equipment, regional medical equipment maintenance workshops, at least in all the regional referral hospitals. But however, the regional referral hospitals surrounding Kampala, they are maintained by Wabigalo. And then Mbarara is maintained by Kawale. So you can see we are lucky up here that Arua has its own, Gulu has its own, Soroti has its own, and Moroto has its own. I always like talking for the entire North because Gulu is a regional city. Gulu is a regional, the original plan for Gulu is that it performs the function of the entire North, and that should not change. So, Roth, you make sure you don't give your birthright to another region. Yes. So the aim is to document, maintain, service, and redistribute medical equipment in the region. And that is a very important function, because if we calibrate these equipments wrongly, we shall be putting you on medication without disease. So the team usually collaborates with the chief administrative officers, the district health officers, the medical superintendents, and the in-charges of these facilities. We rarely go below Health Center 3 because there's other teams who maintain that, and the equipment down there is not so sophisticated. This team coordinates the infrastructure, coordinates with the help of the infrastructure division of Ministry of Health, which is based in Wabigalo. The cardinal outputs here is efficiently maintained, correctly calibrated, and properly documented equipment, and you distribute it in the region. So they are also advisory to local governments on planning, identification, procurement, and installation of this equipment. This is where most of government investments go, apart from investing in construction. Some of these equipments are so small, like the monitors, which very many had not seen before COVID. And I really want to thank my elder, Dr. Peñito. I'm one person who celebrates COVID. It's a very good disease. It has opened our eyes, and it has made us behave well. Actually, we are getting so much investment in 1 to 2 years, which would have occurred over 15 years. So, His Excellency also said it. This is my disease. Why do you want to benefit from it? And I quote, disease comes for you to learn. So we shall also open our eyes on making our own vaccines. Next. This is the second part of the discussion I wanted to make. So we really want a continued support for promotive and preventive healthcare services using our tools. We want this to reach up to the local communities. And I'm so happy with the AMREF lady. I was telling people, I wish after here, I go and become the LC1 of my place. In China, the secretary to local council 1 is a PhD holder. But in Uganda, the secretary to LC1, they barely write their names. And that was deliberately crafted. You are crafting up the parish development model, which is very good idea. And actually, we in health shall be the most beneficiaries of it. But who are the supervisors? On RDC, I think I need to tell you that you withdraw all the principal assistant secretaries to go down to head the parishes. That is now where things can work. Because if I send a medical officer there, who is going to supervise him? He's going to bully everybody, isn't it? If I send a principal nursing officer there, who is going to supervise her or him? He's going to bully everybody. So there must be a framework, a structure down there for these people to perform. Services must be extended to refugee communities, using our own tools and our equipment. By the way, there is a budget for it. We get a budget for it. Quarterly, annually, we get close to 168 million for equipment maintenance in the entire region. Our interest is to be far-reaching so that we can enhance these services, especially in the new emerging policy areas. Screening for NSCDs, screening for common genetic defects. All this should be done using our equipment. Then we should also create an awareness for palliative care and so on. So the main cardinal issue here is, what do we use this equipment for? We use it for enhancing diagnostic services. laboratory, radio diagnostics. These regional referral hospitals have been earmarked for CT scans, and the money is already there. It will come. And Gulu has been earmarked. Gulu has been earmarked for MRI. These are not new equipment. CT scan came out in 1962. Even before, I don't think my mother had developed breasts even. Is that okay? But up to today, there's no CT scan somewhere here. The nearest is Abe. I hope it is working well. Then we're also interested in this equipment to strengthen research and development. Let me tell you something. When COVID broke out, I collected blood samples. I called it clinical blood samples because I'm mandated to collect clinical blood samples. Is that okay? Yes. No hospital in Uganda did it. We have these samples. Now we are the one handing it over to UVRI for research. You can imagine. Isn't that farsightedness? We were not collecting it for research. Regional referral hospitals are mandated to collect clinical blood samples, like how I collect urine from you, how I collect blood for malaria. Yes. So we are going to be a very big center for research for COVID. And I'm very happy that the UVRI is developing a point of test using our own blood here, our own system. So we shall strengthen research and development using what we have. I still want to quote His Excellency when he says that no one should benefit from my disease. It is mine. Let me benefit from it. And then we shall see. If you want to do research, the legal protocols can come in. We shall give you after the protocol has been approved, but the samples are ours. Next. This is the human resource for health we want, really. This could be an offside slide, but I deliberately put it there because I'm following my time. We really need clinical leadership. Our elder, the DHO emeritus, has talked about it. Yes, we are performing very well as a regional referral hospital, but we are relying on the university. And we are also relying on consultants from Lacho. Out of the 4 senior consultants, we have only 0. Then out of the 12 consultants, we have 0. Of course, the only senior consultant is the director. You cannot become a director if you are not a senior consultant. Is that okay? So you have to work hard. Medical officer special grade, we have 5. The good thing is they cover all the major departments. For example, I have 1 obstetrician, but I get 3 obstetricians from the university. I want to thank Gulu University for that. I have one surgeon. Gulu University gives me 2. I have 1 orthopedic surgeon. Gulu University also gives me 1. I have 1 physician. Gulu University has 2. So this is a kind of collaboration which we don't want to throw away. I studied from Makerere University. I didn't know that Malago didn't belong to Makerere University. We thought it was part of Makerere University. But today, people are coming up, the young generation who studied in these facilities are trying to bring up new hospitals, but I wish them luck. We also need nursing leadership, very important, so that this should be at a managerial level, the SPNOs, the PNOs, and the SNOs. These are the people who can teach discipline. They can enforce discipline. The most important thing in training is discipline. If you are indisciplined, you can never learn any science. Science is observational discipline. If you fail, if they tell you to pour chemical A into chemical B at this amount, you pour it using your local amount, you have failed the experiment and you get an F9. So you know what happens. You go home. So it's very important that we teach discipline. And that's why I insist that all the DHOs must be appointed so that there is leadership. Then these senior consultants, the good thing is Commissioner HR is here. If you have failed to recruit senior consultants, because they are now crossing over to the university, here we pay them 8 million. The other side, they are paid 15, 16 million. Definitely they will not come. I promise you. So the only thing you can do is to recruit them on contract. Contractual recruitment. Get these people, give them brand new pickups. They will work. And let them take it home. If we can give MPs pickups, what about them? And it should only be senior consultants, because not everybody should be a general. Then there are new policy environment which are emerging, especially emergency medical services. These ambulances, we already have some, but more are coming. And each district is going to have an ambulance, but it will be controlled by the regional referral hospital. I already even have fuel for all the ambulances in the region. Is that okay? The EMS ambulances, emergency medical services ambulances. I think the principal hospital administrator must have distributed the cards. Unfortunately, you cannot lend the car fuel. You cannot lend the RDC fuel. If we learn it, we shall withdraw it. That is how strict we are. Next.
5 minutes, please.
Yes, please. That is the reason why we needed clinical leadership and nursing leadership. I've already I talked about it. Then we need to repurpose clinical leaderships in the lower facilities. All these guys must be appointed, and they must carry appointment letters so that they develop trust and interest in work. My background is totally local government. I started in local government. I started as a medical superintendent, Moroto Hospital, for 11 years. I went as assistant DHO. I went as a DHO for 3 districts. I think my elder cannot even did not beat my record. I was appointed, not acting. And I think I was amongst the few DHOs in Buganda appointed. Don't you think it is a privilege? Yes, I'm not a homeboy, unfortunately. That's why you will see how I end my discussions. So we need to put leadership there, and Commissioner HR will explain that. Next. Now, there were a lot of issues discussed about vaccines. I think I wrote about that woman in the New Vision and the Monitor as an opinion columnist. That lady, Kathleen Carrico, is the one who discovered the mRNA, that it can smuggle in vaccines. But she developed it for medicines. That thing is very fallible. That means it doesn't resist for long. But unfortunately, she was even dismissed from a university because of that. And that was 1972, when I was just 1 year old. Little did we know in 2010 that it would be used as a vaccine for carrying vaccines. So she won that prize on the 9th of September. So the reason why I'm doing that is I want to tell people that this is science. It is really science. It's not gambling science. This AstraZeneca, they have immunized over 300 million, more than that, 600 million, around 600 million people around the world. I too got it 5 or 4 months ago. I've never run mad. I'm not walking upside down. I have no power bank batteries. I'm still okay, very active. I don't use power bank. So, why are you talking about it? Social media is one of the things which has made, you see a P7 educating a university professor on social media. that when you put it here, it is a magnet. And then the clots. All the women who give birth get clots. But have they ever died? Very few. There are more clots in childbirth than immunization. So I think I've been writing a lot about it as an opinion column in the dailies. We need to change our attitude. The last one I wrote is, can you kindly switch off that? The last one I wrote is frontliners either take the jab or else. This is this one here. I want to explain what Zimbabwe is doing. Very many countries are saying, we cannot do this unless you take the vaccines. The vaccine passport has become a vaccine passport. So the issue is, you heard what His Excellency said yesterday. By the way, what he says becomes a policy. His directives are policy, and his directives are law. If you don't know it, kindly go and read about it. That's why he can wake up and say, let's go for war, and you will not refuse. So, he wanted the cows, he wanted the DHOs. I think he forgot that the directors were around, which is also good for me. That means my job is not at stake. That means my job is not at stake. So please, ladies and gentlemen, let's encourage our people to take these vaccines so that other parts of the economy can be opened up. Let's leave out social media and we zero on science. If science fails, then it wouldn't have been published. Is that okay? This time science has not failed. A few things which were brought, I feel we should talk about. One of the issues which came out clearly is re-engineering public policies for social development. The emergency medical services is coming up, and we are putting up facilities. Just because if you see government policies on roads, the road surfaces are improving. Now, when the road surfaces are improving, people buy good vehicles. When people buy good vehicles, a good vehicle cannot get accident. It is you who will get accident because you have a bad behavior. Is that okay? So we are, as a region, we are not going to run away from improvement of road surfaces, which is meant for other works, but it will give us more accident victims. The other day I was following a bus. The bus was moving at 140 kilometers per hour. I followed it for 10 kilometers. I really wanted to know this man's speed. Unfortunately, it was a man driving. Then when I overtook him, I just shook my head. Of course, I have to overtake above 140. So he reduced his speed. So some of these public policies, you cannot run away from it. So as a region, let's prepare for the emergency medical services. Ladies and gentlemen, thank you very much. Ruth, I appreciate your presence for coming to sit with us to discuss the fate of the region. Thank you.
Thank you so much, James. I think you are turning into a politician. You completely changed the topic, but that was really good. Please give him another round of applause. Yes, please allow me to welcome our commissioner, Dr. Patrick Okello, who is going to talk to us about performance management.
Chair, I will request to be allowed to address members while seated. The topic I'll be sharing with you is about performance management, the dilemma of enhancing productivity of the human resources. In the interest of time, I will jump very many slides so that I am able to deliver within the 15 minutes allocated to me. My first slide will be slide number 4. When I tell you number 4, Secretariat number 4, I'm starting on slide number 4. The slides are numbered. What is performance? Performance is the measure of achieving or failure to achieve a desired result against a set target. Whereas, on the other hand, management refers to the process which enables an organization to achieve its objectives by planning, organizing, and controlling its resources, including gaining the commitment of its employees. That definition is by a renowned academician by the names of J.A. Cole. I want us to go to slide number 6, which provides the objectives for any performance management system. And this includes improving planning and work processes for improved productivity, encouraging the early identification and turnaround of unsatisfactory performance, linking tasks of each employee to the overall objectives of the organization and the national objectives, reviewing performance objectively against agreed standards to enhance the capacity of the public service to deliver its services effectively and efficiently, and lastly, to reorganize and reward outstanding performance. Talking more about the performance model, I would like to request that we go to slide number 9. Slide number 9 provides the integrated performance management system for the public service. And it clearly defines what's involved in performance management. You start by setting the entry point is performance planning and budgeting. That is the most important stage. When you have done the planning and budgeting, then you conduct the performance review with a view of ensuring that what you have planned for is implemented. After the reviews, then you'll move to the review and recognition of good performance so that the good performance is rewarded and poor performance sanctioned. After that, you go to monitoring and evaluating performance. And when you have identified the performance gaps, you go to the next stage, which is capacity enhancement. This really involves addressing the performance gaps through capacity building and also retooling. And when you have done that, you go to standard setting and then preparation of client charters. When you reach that stage, the performance planning cycle starts again. And all this results into results-oriented management. Secretariat, let's go to slide number 24. Now, what are the dilemmas of, what's the dilemma of enhancing the productivity of the human resource, both in the private sector and in government? The first one is commitment by the leadership is critical. And we have noted that both in central government, in the local governments, and in the private sector, unless there is commitment, you'll never realize a productive workforce. We've also learned that the next dilemma is the need for involvement of all stakeholders for a shared vision. And many a time this is lacking in a number of organizations. And this causes a decline in productivity. The other one is clearly defining the concept based on specific circumstances of the country and supporting the work environment, inter and intra-linkages of key stakeholders. This poses a big dilemma because in a number of organizations, you find that this particular concern is lacking. The next dilemma is the changing attitudes and the poor culture of some workers in some institutions. This poses a dilemma in the way that if you have a negative attitude towards work and a poor work culture, then you're likely not to deliver up to the required standards. Learning to recognize exemplary performance of individual public officers is still episodic because At times, those who are good performance are either viewed as a challenge in the organization or unfairly treated. And of course, the need to sensitize public officers. What are the challenges we are facing in rolling out and in implementing effective performance management? The first one is lack of baseline in performance. I think this is cross-cutting. There is also the challenge of implementing performance initiatives in a disjointed manner. Just like the director here was saying, why don't you recruit? And yet the responsibility to declare the positions for filling lies with him as an accounting officer. So a disjointed way. Why don't you provide vehicles for senior consultants? And yet the responsibility to budget for these vehicles and engage finance lies on the accounting officers. We are also having a problem of non-institutionalized performance management in all MDS, and I want to thank Rights North, the USAID support. I think that has been an area where you have invested very heavily. There is a challenge of ad hoc assignments which cannot be easily assessed, inadequate and unpredictable resources, lack of client charters and services standards, and then failure to implement change management. We also have the issue of the work environment, which is not conducive to encourage and support individual performance appropriately, to apply their knowledge, skills, and attitudes towards achievement of organizational objectives. I've been deploying medical officers, specialists to Gulu, but they don't want to leave Kampala, simply because they feel the work environment is not conducive. What they call the urban tourism, unless government addresses the urban tourism, where the health workers, the local government staff, central government staff, don't want to work in rural areas. It's a big challenge. Rewarding good performance and punishing poor performance. I was talking to a group yesterday and I was saying that unless politicians learn to divorce politics from the independence of the public service, we may not be able to realize the best, and then failure to appreciate the benefits of managing performance. Way forward, what should we do? This calls for jointly planning. We need joint planning, monitoring, evaluation, and improved performance. We need to identify and promote benefits of performance management. We need to manage performance throughout the year. We need to align employee goals to the goals of the unit. What is killing the public service, both where I come from in Ministry of Health and in the local governments and in hospitals, is something called the loose minute. People take more time chasing for allowances than even the time they spend working. I don't know who introduced this thing called loose minutes. Claims for nights that are never worked for. We need lessons on learning and feedback. We need to capture good lessons and disseminate them. We need to improve communication to be approachable. We need to maintain performance data. We need to focus on the results and qualitative results. We need to identify causes of poor performance, manage conflict with grace, harness diversity, use progressive disciplinary approach, start reviews on the right foot, and prepare for the appraisal. We need to encourage counseling, identify and promote talents, and encourage and promote continuous learning and staff development, which is demand-driven capacity building. I must say that we must accept and learn to be servants of the public and not the bosses. I want to conclude by saying that performance management is an ongoing process throughout the year. It involves performance planning and so on, as I mentioned earlier. It's not only about performance appraisal, it's about preventing and solving performance-related problems. A poor performance management system undermines the credibility of management, and organizations which do not perform will never achieve their mandates. And in order to improve the public service of Uganda, we need to put in place stringent performance contracts. I've worked for the UN I've had opportunity to work for the UN 4 times. And in the UN, the targets are so stringent. I was in Afghanistan, I stayed in Kabul for 1 year. Now our beautiful country has been destroyed. And I was working under the banker and delivering. Some of you fear even going to Karamoja here. I've worked in Iraq. I was an advisor in South Sudan for quite a long time. So really, unless we revolutionize and adopt the private sector tenets in the public sector, we shall still remain a questionable public sector at whatever level. Where you get policemen at night trying to stop doctors yesterday, and when you tell them what's the problem, Muzei, can you get me some 200 for chapati? That is your public service. I want to conclude by saying, and this is by President W.J. Clinton, that chart a course for every endeavor that we take the people's money for. See how well we are progressing, tell the public how well we are doing, stop the things that don't work, and never stop improving the things that we think are worth investing in. I submit. Thank you, Chair.
Yes, thank you so much, Commissioner, for sharing those beautiful thoughts and also sharing your experiences on the different tasks that you've undertaken. You've saved us some time. You've been right on time. So I'll quickly move into the next discussion. Give Dr. Hilary Alim a chance to share his thoughts on the private not-for-profit support.
Good morning.
Good morning.
Again, my name is Alima Hilary. I'll be presenting for UPMB and bring greetings from my executive director who was not able to be here. And just to mention that I'll be talking about strengthening health systems for better health outcomes, looking at the experience of support for PNFP facilities, but also being able to draw on the experience of UPMB specifically to speak for the medical bureaus that support PNFP facilities. Next, I'll try to be fast to save on time. So that will be my outline. Next slide. This is a structure that just shows how we work. So you have the member facilities at the bottom. We work very closely with the districts and the health coordinators for the different dioceses and different religious structures. And then definitely the bureaus are above that. And then we do have an inter-bureau coalition that we work together to make sure that we can enhance the synergies that come from working together. This is just a background to show that we are a number of medical bureaus, the Catholic, the Protestant, the Muslim, and also the Orthodox medical bureau, and we do work very closely. Next slide. I hope I'm not too fast. So this talks about the numbers, showing the majority of the facilities are under UCMB and UPMB, and a few are under medical Muslim, and then also Orthodox. Next slide. Just a brief introduction, UPMB, Uganda Protestant Medical Bureau, and I'm going straight to the experience of UPMB, was established in 1957 as a non-profit organization. And under UPMB, we do have Church of Uganda, we have Seventh-day Adventists, and also the Pentecostal churches. And so we're supporting about 305 facilities and then 16 health training institutions, and we're supporting health services. We are coordinated through a number of regional, but also district-level coordination structures that include religious setup structures. Can you just reduce it in size? Yeah, thank you very much. So the key partners, I will not go through them, right from Ministry of Health, which is giving us oversight, down to PEPFAR, that is greatly contributing to our work, the medical bureaus that we work with, district, local governments, to other partners that I will not mention. But I must say at this point, Rights North Acholi in this region has been very helpful in supporting us. The table at the bottom shows the number of facilities, but also the breakdown of the number of facilities. In Acholi, we do have about 13, but I must say that excludes hospitals and health center falls. So we do have a big task in making sure that these facilities are able to get accredited and become a higher levels of service. Next slide. Next. So this is just an example of our contribution. The scripts may be small, but I'll just talk through them. So one of the things that we do is support community health insurance. And why do we do this? Because most of the facilities that we support are in the rural areas, and because of that, we do have the experience of having a number of clients that do not have enough out of pocket to pay for the services. So most of these facilities have ended up negotiating dates and flexible payment methodologies. But also because of this, it has affected sustainability. So finally, how do you, if someone was brought with an accident and you couldn't send them away and they promised to pay, and then at the end of the day they can't pay, what happens next? How far do you go? Today morning we were hearing about COVID-19 and those who have passed on, unfortunately. So what happens after that? And so because sometimes you have to let it go, it affects the sustainability of the facility. So we are bringing in community health insurance to make sure that communities can bring together their small resources and be able to sustain services. So which are some of the approaches we are doing? We do have provider managed schemes. These are about 62 facilities that we have trained, that we are doing support for, and we have also equipped to be able to run these community health insurance schemes. We are partnering with Equity Bank, insurance company of East Africa, and NAPSAV that gives us IT support. And I'll be showing some figures on how we are proceeding in terms of our achievements. Probably that's a little small for me to see, but I'll read from here. So in terms of achievement, we've been able to collect about, previous slide, about 2 billion shillings coming in with a surplus of about 500 million. And in terms of membership, we are seeing in about 80,000 clients coming in, which I think is also good. We also have another approach where we are working with the different umbrella organizations like Church of Uganda, and we are getting a lot of their communities to come in and receive services, working with about 50 facilities. Okay. Thank you. So this is just a picture of what is happening at the facilities. You can look at the different health centers and then the hospital levels. You can see the amount, the total amount, about 101 billion that is coming in through PHC funds, and we were very grateful to Ministry of Health, Government of Uganda for that support. But also just to mention that these PNFP facilities do cover a significant proportion of the health services in the community. The next table shows the increase. Again, this is something we are grateful for. If you look at PHC funds, 8% increase, 2018, 2019, 3%, 17%, then 220, 221, a 47% increase. That was quite a significant increase in PHC, and we think if this is utilized well, it will go a long way. And this is actually improving the coordination with the district structures in terms of support and oversight. Next slide. So we also have support for governance, leadership, and then HRH training. And in terms of governance, we believe that even if all these resources come through, if governance is not good, then we will have problems. Structures will collapse, we can't account for resources. So this is a key area for our support. So we want to see good governance, we want to see development, and finally sustainability. One of the reasons we are also doing the community health insurance. And the other very critical need, I think, for the PNFPs is the HRH. There is a very high staff turnover. If you go to PNFP facilities, most of them that are fairly established, the services will be good. The capacity will be built, but at some point, many of these will cross over to public facilities, mostly because they are paying better. And because the facilities, the PNFP facilities, are trying to get some form of sustainability, they cannot just raise their salary scales and be able to suit what is available in the public sector or in the private for profit. But as the PHC is coming in, we are seeing a lot of support coming in. But also to go back to what Dr. Elima said yesterday, which is very critical, on the area of posting staff at the PNFP facilities, that has been very helpful because they are stable. And then if we're able to support them well within that environment, actually the results are good. And I'll be talking about some of the things that we are doing in terms of training. So to make sure that all these resources that are coming in, we are also trying to support HRH. We do have training of board of governors, and we've had, I think, quite a number in the last year. We do support strategic planning and policy development at facilities. We participate in their board meetings. We have scholarships. We do offer up to 30 scholarships per year to health workers, and I think this year the number has increased to 35. So yesterday when I was hearing you talking about posting a surgeon and the need for an anesthetist, we're thinking this is somewhere we can partner. You bring a surgeon, we train an anesthetist, maybe a theater nurse, and together they're able to churn out the kind of results that we are talking about. And then supporting for HRS performance management, and I think our commissioner has really highlighted this. This is very critical. So while you're bringing in all this stuff, all these resources, the area of looking at performance management, very critical for us. Then continued advocacy. You could zoom in. These are numbers. 12 boards we've supported, 28 hospitals that we have drafted strategic plans, 31 scholarships last year, 35 this year. And we are thinking of how we can strengthen this process. We're asking ourselves, can we pick up very good performers? Can we address critical needs? And trying to look at the criteria such that we are meeting the needs. Managers have been trained in governance. We have gone also to restock health training institutions with books. Lots of books we are getting into this place. Then the health training institutions, about 2,606 personnel that have been trained. I don't know if that is supposed to be happening, but I can continue. Okay, thank you. So some of the regional achievements in Acholi, we have about 181 staff that we are supporting. We have given scholarships. I think last year there were about 3, and this year we hope there will be more. This is a representation of the distribution of the health workers, about 6,034, but that is only 66% of the need. So you can see that gap that is there. And then the training institution, that is the data. Next slide. Next slide. So we're also into infrastructure, equipment, and lab support. Began very small, but is growing by the day. About 11 facilities benefit from this annually. We are being supported by a German institution, Bread for the World, that is giving us some resources. But what we are seeing more and more is the need to work with the Ministry of Health Infrastructure Department, and also the district to make sure that we are supporting the right kind of constructions. I've gone to a place where a facility received resources to construct a theater. But because of the way they did it and they didn't seek appropriate guidance, when they finished and they came to inspect it, they were told this can only become a hall. It cannot be a theater. So you can imagine after constructing and they tell you this cannot be a theater. So we are trying to work very closely. So 11 facilities, and then we are assessing another 11 for support this year. We've been able to give them equipment in response to COVID-19. And then also 5 incinerators that we have built in the last year, lab mentorships, about 107, then accreditation for 4. Next slide. Thank you. That is just a pictorial, some of the equipment that we are giving out, and then the construction work that we are doing to support facilities. One of the things that we want to see is if facilities can move from one level to the other. It means that they can actually get more support because of where they have reached in terms of infrastructure. And so we're trying to respond to the different needs. Also looking at coverage in terms of the population that they serve. Next slide. So this is another very big area, and I must say this is one of the areas that we are trying to work closely with the Ministry of Health in terms of quality assurance with the quality department, or rather to see that we improve in this area. And I must say recently, I think there's been a big push towards COVID-19, but we have not left the other establishments for the QI, and we want to see how these facilities are able to fit within the regional structures and participate in what the region is actually doing. So we've had training of teams, we have had risk assessments for facilities, and then we are also going into WASH and IPC, and we're also looking at, we are distributing SOPs and also IPC materials for these facilities. So one of the things that we want to do with that is to make sure that the team from Ministry of Health that does do the quality assessments can come and also bring us to par with what is going on. This is just a pictorial of the support that we do in this area. Next. So these are some of the outcomes you see from health service delivery: 10% increase in the number of beds, 2% increase in OPD, and I know COVID did affect us much in that place because the previous years were better. 3% increase in deliveries, 9.3% in staffing, 6,000 more people brought in within the year, 66% staffing. Like I said, that does not look good. We hope it will get better. I will not repeat some of the areas I've already mentioned. 100% of member health facilities accessing and reporting in DHIS2. Just to mention, 80% web-based ordering, and then 23% of the health facility implementing community health insurance. And then RBF, we see about 6% income from that. 27% functional health facility management boards. This is very critical for oversight, and we are seeing that as we continue to support the coverage of this and functional health facility management boards, we are having good governance coming out, good utilization of resources. The area of sustainability is actually improving, and then some trainings in grants and finance management. Next.
5 minutes, please.
Okay, I'm about to finish. Thank you. Contribution, UPMB member health facilities, and that is looking at the number of clients. If you could just, thank you. If you look at the family planning use, that is quite commendable. If you look at the number, 148,000. You look at OPD attendance at about 1.6 million. I think those are some of the critical things. Immunization at about 86,000. Next slide, next section. Thank you very much, Secretariat, for that support. So this, you could reduce the size. Sorry about that. So for UPMB HIV project outputs, you can see the numbers. We do have close to 160,000 on treatment, which is quite a considerable number, looking at the national figures, but also a suppression rate of about 94. If you look at contribution to non-communicable disease, this is an area which has been way neglected. We went through and did have a number of facilities, trained about 35 facilities that we support, and we are scaling this up, and we're able to identify a number of cases, support them in lifestyle change, also providing some equipment. Next slide. So I think this is I think the most important slide for me. So the previous slides were just giving a picture of what is going on, but this is very key for me, and for definitely the private not-for-profit. So they need to address persistent high staff turnover. It was so bad that recently, while we're doing entry meetings for a new project, that is LSDA, funded by USAID, one of the districts informed us that they have trained one facility in the revised HIV guidelines thrice, and even now they do not have trained people because they left. And they're telling us if that facility stabilizes, we'll come back and train. For me, it spoke volumes to me in terms of stabilizing that. And so we're trying to work closely with the district to see how we can do this, working also with the medical bureaus, Ministry of Health, but also the facility boards. Then we need to see scale up of result-based financing and community health insurance for sustainability. And then working with the district local governments for accreditation of facilities, and this is very important for us. Need for increased coverage primary health care grants, and I must say there's been a significant leap in the last year. We are appreciative, but we think more of that would actually go a long way. So we also want to use the scholarship schemes to be able to support these facilities, retain staff by bonding them, by getting them to do a better quality of the work they do. So, but from the sessions that we've had, a number of things that come up. In terms of the structure, I think the whole regional referral structure, and I picked up the area of HRH support, which I think would be very critical for performance. But also one of the critical things that came up, we did have a baseline assessment for the facilities, working with the different stakeholders. And I think a critical thing that came up is that there's a need for a better working between the PNFP facilities and also the districts, and then also the regional referral. We know there is a lot of work that has been done here, but we think if this is strengthened, it would actually make a lot of things move in terms of support, supervision, but also taking some of the load that is coming to the regional referral and other hospitals. Thank you very much, Chair.
Thank you. Thank you so much, Hilary, for sharing the UPMB LSTA journey and support that you've been providing in terms of service delivery. We have one last presentation before we break into the discussions and lunch. And I'm just checking if Mabel is online so that we can begin the last discussion.
Yes, I am.
Sharing SBCA's experience lab. IT, can you check if Mabel is online? Yes, please go ahead.
I am online.
Please unmute her.
Okay, good afternoon, everyone. My name is Mabel Naibere, and I'll be presenting for USAID Social Behavior Change Activity. My apologies, I couldn't make it to be there physically, but I have representation from my colleague, George Olanya. Please go. Just to introduce myself a bit further, I work as a human-centered design specialist with the project. So just a brief introduction about our project. It is USAID funded, and it is a 5-year project. Started last year in April, and it will go up to April 2025. And we are a consortium of 5 partners, with the Johns Hopkins Center for Communication Programs being the prime. And we work with Busara, we work with the Medical Concierge Group, we work with World Vision and WIHA, which is Women Influencing Health, Education, and Rule of Law. Please go. So our vision is to see a Uganda where individuals and communities are not just healthy, but they're resilient and they're supported by strong and adaptable systems and institutions to lead to productive lives. So we are not only looking at communication, but we're looking at as the general or the broader picture of the 360-degree interventions that influence life in general. Please go. So in SBCA, our major goal is to have improved adoption of priority behaviors at the individual, household, and community levels. But we have 4 result areas, and the first one is to have internal social and structural factors that affect adoption of healthy behaviors, identified and used in term to inform SBC interventions. And I'll just say that SBC is social behavior change. The number 2 is implementation of evidence-based SBC interventions scaled up to cause change at population level, and also seeing SBC capacity strengthened and institutionalized, but then also information management services systems enhanced to increase accountability and informed decision-making. Next, please. So now we're going to go into our experience lab, which we're here to talk about today. So in SBCA, we realize that usually how technical assistance has been provided and capacity strengthening or capacity building, or whichever you can choose to call it, usually it is externally driven, and it is not driven from the side of the people who really need it. And usually people look at technical assistance and capacity strengthening as someone, an expert in quotes, who usually comes from far, from outside, they don't really relate to them, arrives probably in town or a hotel, and runs a workshop or helps with a task. And we say that this can be valuable, but us as SPCA, we recognize that we need to do things differently. We need to have disruption in the way we provide the technical assistance and capacity strengthening from the past. The way we've called technical assistance is not the way it should be done. So for SPC interventions to succeed, we are cognizant of the fact that there should be demand among partners. There should be demand from the people that actually need the TA, the technical assistance. For us as USAID SPCA, we sought to redefine the way we provide technical assistance. We are using some new models or novel models to offer tools and expertise And we are putting implementers in the position of consumers. So implementers being, for example, the districts, or being the Ministry of Health, or being the partners, to be the consumers of what we are actually providing in terms of TA or capacity strengthening. Please go. I can't see the please, okay, thank you. Please go to the next slide. Okay, so this is what we are calling our experience lab. The lab has 3 components. No, please, previous slide. Previous slide, please. Previous slide, please. Okay. We are saying that our lab has 3 components. It has a virtual component, it has a roving component, and a physical component. And we'll dive a bit more into each of these in the next slides. So it is a collaborative space of behavioral science and design thinking, expertise, and excellence. So whether roving, whether virtual, whether physical, which you shall understand a bit like I said, it is a space where IPs, where implementers, where stakeholders come together to think about problems in line with SBC, social behavior change, and to find solutions together, collaboratively. And we are saying that space facilitates deepening of knowledge of local behavior determinants. So we are saying that we never want to design things from the boardrooms like we have been doing from the past. From all the things we are doing moving forward as SBCA, we want to do things from using the local expertise, using local determinants, using the local knowledge, and rapidly and iteratively co-creating SBC solutions with the end users. So you'll see that as we co-design these, we actually work with the end users who are the audiences as we design the SBC interventions. We also provide real-time practical guidance and tools to SBC implementers. So if there is need, for example, for people to design interventions, design SBC materials or tools, we provide the real-time practical guidance. And our Experience Lab helps to turn partners, like I said earlier, into the consumers of valuable SBC technical services. And also the technical services, we are saying they cut across a multitude of services. Some of these could be the design of tools and interventions in line with SBC, testing them together with the audiences, implementing them collaboratively again, monitoring and evaluation, collaborative learning and adaptation, the capacity strengthening, and the coordination of SBC interventions at different levels. So we are saying any kind of technical assistance you might need as a stakeholder, as a partner, we are able to provide this. And also to note that sometimes some of the partners, for example, you might see that Rights North Acholi has done something good, and this can be cascaded to other partners, so they do not have to reinvent the wheel. So we get the expertise of Rights North Acholi, and they provide that technical assistance to another partner who has a similar problem. So most of the times we are not the ones probably doing the giving of the TA, but we work through the network of SBC practitioners. And also individuals and organizations, we are saying, can access the Experience Lab anytime they want. We have a lot of requests coming in through applying through our form. We have a request form and link that you can apply through if you need to get any kind of technical assistance through the Experience Lab. And when we get the request, usually we provide the necessary technical assistance depending on what the problem is, depending on the magnitude, and depending on the timelines that we are working with most of the times. Please go. And I mentioned that I'll talk about the different modalities of the labs. The virtual lab, like we're saying, this is virtual. Right now I'm working virtually, we all understand this. And because of the new realities around COVID, the world has changed. So sometimes you might want to participate in our processes, but you're not able to be there, physically. You can do this at your convenience. We are using the lab. It's a simulated environment, really typically implemented through a virtual space and access to the internet and other digital tools. So we have a virtual space that we have created where we can do the learning, we can do research, you can access a lot of resources. So we are saying we have, for example, the Uganda campus, and usually we get requests for SBC tools, SBC materials, IEC materials. But if you go to, if you came to us and had a request, for example, for any kind of SBC tools, we just go to our Uganda campus, which is housed on our virtual lab, and we provide all these materials that we need or that are ready. And these have been approved through all the right channels, because we usually do not publish any materials, not until they are approved through the various channels, the approving boards. It also consists collection of materials, resources that are being developed using the best practices of SBC, like I mentioned earlier, and with compliance with government policies and guidelines. So anything we develop, anything we end up disseminating has been approved. And if you came and requested through our virtual lab, you will really get access to most of these materials through our Uganda campus. Please go. And we have the roving lab. Now, the roving lab, like you hear the word, is not situated in one place. It keeps on moving. So if you can't really access the virtual, if you can't access the physical, and if the problem needs us to be with someone, we'll move. Our team of mobile people moves from Kampala and finds where we are. For example, the photo you're seeing there, we're just in Napak, just a few weeks back, and we're looking at areas around MCH, maternal and child health, So we got a request from New York and Apollo from Karamoja region, and we were just able to go and diagnose what the problems are to see how we can collaboratively design SBC interventions for the people there. So this one, again, we are not situated in one place. We've been to so many places. We've been to Masaka doing things around PrEP. We've been to Fort Portal doing things around the HIV cascade. So we've been to so many places. Again, this allows us to co-create and test interventions together, increasing the likelihood of success. And we are always in place with the end users. Like here you see we're with the mothers, trying to create things that work with them collaboratively, hearing from them and making sure we are not designing anything from our heads and from the boardrooms like we have done previously, Usually we come to a place, it can be anywhere, like you see here, we're seated under a tree, it can be in a hall, it can be in a community center, at a facility, in a hotel, depending on how appropriate it is and the nature of audience we are working with, we can move anywhere, like I mentioned. So it keeps roving and it keeps changing. And the user experience is backed up with our SBCA designed evidence-based capacity strengthening strategy. So we have a strategy under which we do this. We provide this TA. We just not wake up and say, oh, they have requested, let's go. We always have a thematic way in which we provide this TA and a strategy that guides the TA we provide even through the roving lab. Please go. And we have finally the physical lab. This is an innovative and comfortable learning workspace, and it's situated at our offices in Bugolobi. Just in case you want to come and do something in our lab, we're in Bugolobi, 4th floor, Union House, plot 78, along Lithuli Avenue. So here we still work together to co-design, to test, to learn, to collaborate, and to document processes, campaigns, and approaches in line with SPC. So we sit here sometimes with the ministry, sometimes with district representatives, sometimes with partner representatives, sometimes with students, name it, depending on our audience or the end user at a given point. And we work together. Our physical lab is in the process of being finalized. COVID really affected us very much, but if you really need to use it, you can always contact us, and a big part of it has been set up, so you can always go. Come and have a feel of what it is. If you need to have hands-on experience with SBC interventions and development and everything, research around that, please go. So we're going to see some of the things we've done through our lab, and you can go to the next slide. Just to
Mabel, you have less than 5 minutes.
Some of the things we've done through our lab, we've supported the Ministry of Health and partners in the development and rollout of umbrella communication campaigns. And some of these include a big campaign we have designed, and it's at approval level. Actually, we have 3/4 way approval. The Time Up HIV campaign, which we are going to be using. And this is premised around the 95 HIV treatment targets of ending HIV by 2030. We have developed this collaboratively, not just us as SBCA. We have developed a cervical cancer screening, prevention, and management campaign, and this is also at the level of that approval. We have the Chijakugwa COVID-19 prevention and management campaign, which has been rolling out. It has been everywhere, TV, radio, name it. And with also something key here is that with the support of the Experience Lab processes, we're able to support Lango region's COVID-19 vaccine average coverage to improve from 15.5% on 5th May to 76% on 35 May 2021. And this is backed up by data that is available. And we've also provided technical assistance to the Karamoja region implementing partners and applying human-centered design approaches to design a Karamoja-specific SBC plan. This is in place and ready for use. And we've hosted a virtual learning event on strengthening demand generation and service delivery for postpartum family planning and post-abortion family planning services. And we have experiences from implementing partners. They were shared and a lot of learnings. We had over 120 participants. And we've also supported Ministry of Health with engagement of private sector bodies and kingdoms in development issues, including COVID-19 and HIV prevention. Please go to our last slide. And our key lessons here is that most times our partners and stakeholders equate SBC solely to developing and printing materials, which is far from that. Like we've seen, there's a lot that is done in SBC. So every time we mention SBC, most of the time people think about materials, but it is far from that, and it's something that we need to collaboratively learn and work upon as SBC, as people who work in health moving forward. And there is also, we've learned that there is no need to reinvent the wheel on most issues. Partners are doing a lot of deep their work and sharing their work. We have learned that most times there's no need to you just need to come to the lab, understand what someone else is doing, and probably just tap into that expertise and what they already developed, and just move ahead to solve your own problem, or probably tweak it a bit. And there's also need to leverage the Experience Lab to enhance learning, knowledge management, sharing, and testing of interventions. So we learned that there's a lot that has been done by partners, but we are not sharing as partners. We are not sharing as districts. We are not sharing as stakeholders. We need to always come together, have an avenue to share our learning, to share our learnings, our knowledge, what we have done, our best practices. And also because most times we do not understand our audiences as SBC practitioners, we implement wrong channels. We end up developing things that do not work for audiences in the boardroom, and we use the wrong channels. For example, when we were in Karamoja in Napak, we learned that these guys almost never listen to radio. And for us, most times we take our interventions on radio and we say, oh, we have a radio ad, but they are not listening to it. So our message is not getting to the end user. So we need to work through such ways to understand what works for our audiences. And also public relations approaches are critical in addressing SBC issues across all thematic areas. We've learned this, for example, during COVID, that it's not enough just to provide knowledge, to provide information, to provide the vaccines, but you need to manage the public relations. You need to manage how people perceive the vaccines, how people perceive your information, for them to be able actually to take it up and to take up the vaccine that you're promoting. Otherwise, you have the information, they'll know that, oh, the vaccine is available, or the vaccine probably is good, but they'll not take it up because of their perceptions that they have and how you have promoted it to them. So public relations is very, very much important. And definitely, obviously, the virtual lab has been more popular among stakeholders because of the COVID realities. We cannot move much, we can't interact much in large groups. But also the roving lab has picked up very much because many times we need to move to where the end user is to co-design something that really, really works for them at the end of the day. Next slide. Okay, for Matek, thank you very much and have a good afternoon.
Thank you so much, Mabel. The quality of the audio was actually quite good. Another round of applause for all the presenters today. Yes, we seem to be right on time. We were instructed to allow the team to depart this place by 1, so that means we have less than 10 minutes. We have time for a couple of questions. The MC is trying to tell me something. 2 minutes? 20 minutes? Oh, okay. We've been given additional time, so we have 20 minutes. We can accommodate a couple of questions for each presenter. If you have something burning, it doesn't necessarily need to be a question. You could be sharing an experience or a comment. This is the time now to raise those questions and comments. Just raise your arm, then we can move the microphone around. I think we can take, if possible, all the questions. The presenters can note them down, and then they can answer at once. Can we have someone to move the microphone? The sister has a burning question. Thank you. Just keep the questions brief. Our DHA emeritus after will ask after.
Thank you, Chair and the presenters. I have two concerns. One is within, one is not in the topic, but still is within the health. The first one, about the clinical guidelines, we have the version of 2016. I don't know whether that is what we are using now, because we know that the disease patterns keep on changing. So from 16 to date, maybe we have a new vision. The version I wanted to know. Secondly, I have a concern. I don't know who can answer here, but I was addressing also to the ministry or to the commissioners about the licenses. We have operational licenses for the low health units, also anyway for the other health facilities. That is the annual operational licenses. Now when we have a facility, say a health center 2, with laboratory and maybe the other part, they also need that one. Allied comes in because we are under Uganda Medical and dental practitioners. But then Allied also wants the laboratory to be licensed differently. And to us, we have been discussing, is it really proper? Because the health center 2 with laboratory, also health center 3 for that matter, should we have laboratory licenses separately? Thank you.
Is someone moving the microphone? Please bring it. In front here, please.
Thank you, Chair. Thank you, presenters. I have just to my director, thank you for your presentation, although you left the medical equipment and concentrated more on human resource. But it is expected, because if these medical equipment are not properly managed, then they will not be, so we need the skilled staff, and that is what you really concentrated on. I have no regrets. On social mobilization, because of time, probably we shall wait for Commissioner Opento. Are you Opento or Rington? I used to know your name. Opento, George. I think it is important to involve the cultural leadership in social mobilization. The LC system, they are very important to demystify all the rumors going around. If the whole of me was shaken to the bones, I think it is important that we take it to that level, because they are in close contact with the community. Commissioner Human Resource, you talked about performance management, those cogs in the ROM, results-oriented management, and you talked of those dilemmas, like commitment of leadership and supportive working environment. Among the challenges you really pointed out, inadequate and unpredictable resources. But on way forward, you did not mention any of this. I don't know if you are fearing anybody, or because really these are the crucial issues: the working environment and leadership and resources. I didn't see them in the way forward. UPMB, I just want to thank you, because I've enjoyed a lot of good working relationship with you, good and you contribute a lot to the health sector in Uganda, good partnership, and to the community, they always say you're affordable, affordability of your services, which is very good. I recognize the Ministry of Health for giving the primary health care support, although it is not adequate. But I would like to re-echo what Bishop Leon presented. And I presented to the Health Committee of Parliament when they came following the funds for COVID. I raised this, Bishop Leon also raised this today. The bureaus give us a lot of support during emergencies, epidemics. But ministry doesn't give them the support, the risk allowances. It's only during those days. During Ebola, we provided for all the staff. So I don't know if it is still an issue or somebody is going to answer. Thank you.
There is a hand behind. There are actually two.
Thank you, Chair. Mine goes to the Commissioner Human Resource. I saw something there with keen interest that developing the health workers, okay, should be demand driven. I mean, that is training, sending them for training. And I think most of the facilities do it on demand. Sometimes you find maybe in a whole regional referral, especially in these unfortunate areas of ours, there is one medical officer, and then they identify people to go to school, and then these people come back, and they are not recruited, but interestingly, you find the people who don't want to come to the region are being sent. This cuts across board. You find there are very many nurses in a facility that have been developed to the level of being promoted, but never happens for several years. So how do you address this?
Jimmy, please pass that to your neighbor behind.
Well, thank you so much. My name is Raymond Chan, Secretary for Health, Kitgum District Local Government. My question is directly to my brother Ilri for UPMB. I want to appreciate your efforts to complement the government, especially to our facilities, the P and FPs. What I really expected from you that I didn't hear, if you could also clarify so that I understand. Because the facilities you're supporting, in due course, you will exit. What plans do you have for the sustainability of those other facilities? Because we love them to continue at the level where you will have left them, or they should also step up. And also, maybe you had something later on, whether you have also continuous infrastructural development in line with human resource. I would also love to know, in those other facilities you're having, if you have the local context, you continuously also try to bring and you marry with the late approach, because those are the direction we should also be heading to, so that we have peaceful coexistence of those other facilities. And then finally, as a Commissioner Human Resource also said, I've noticed always there are challenges in succession planning. When an officer maybe is now almost retiring, prior plans for someone to take over, that one disorganizes, it takes long. It normally gets people by storm. And I would love that one to be improved in due course so that there is always smooth succession. Someone goes, someone comes in, and the services, the quality remain. Thank you.
Yes, just two more questions. Please bring the microphone to the front. The two raised hands, I think that will be it. James, there was a comment from the virtual followers about picking blood from drunkards. I hope you saw it. Yes, you need to respond to that.
Thank you, Chairperson, for good presentation so far since morning. I have a concern which I want to direct it to the director. Director, we have a situation. In Kitgum, we have patients of COVID who tested 4 times, and they are positive. They are healthy. In such a scenario, what is happening? 2, testing system, the RDT and the PCR. The RDT normally give us false results. I remember a situation when 8 teachers had their meeting here in Gulu. They were mandated to test. And only one were got positive. The rest were allowed to go, to come. But then when the results of PCR came back, 3 more were positive. And immediately we traced the contact. Out of those contacts, 3 were more positive. So you can see how it is misleading. What can we then do in such a circumstance? Thank you.
Just 2 more. Please pass to, yes, our colleague from UNFPA. We seem to have more questions than the time we have to respond to them, but keep it brief, please.
Thank you, Chair. My question goes to our dear director. We appreciate your support as far as medical equipment maintenance is concerned. I'm wondering how often is supervision done? Because we see many equipments lying around in the lower health facilities, yet they could be maintained. Thank you.
Okay, please pass the microphone around. Let's get all the questions we can. Okay.
Thank you. My name is Stephen, RDC Gulu. I'm glad one of the presenters has been a former employee of the UN. There is a system within the UN which I thought I could relate to the government system for motivational purpose. Can we together join hands and begin to advocate for a gradual promotional system which is equally motivational, so that it's not about the scale. Within the UN, I can join in as a G4/1. But every year I remain consistent in service, I become G4/2. Until G4/8, for my consistent service, I am automatically moved into G5. So that I don't have to wait through the gradual promotional system. Can we ask the Human Resource Department to begin to think something in that line, that your consistency in service comes with corresponding motivational levels of remunerations from government, so that if I am recruited in as a special grade, maybe 2, I don't know what they are, 2-1, 2-2, 2-3, maybe I get to 2-8. And each of these levels come with corresponding amounts of finances. It's my humble appeal that can we begin to review something like this and suggest to government, so that staff feels I have all the reasons to just spend this year or the next 2 years, I am going to be moved to the other category. You don't have to wait and transit through the tedious process of the commission and the rest. It's automatic with your consistent service. It's motivational enough. Thank you.
Yes, thank you, RDC. Please move the microphone behind. The last two hands, you bear with us. We've eaten up the 20 extra minutes that were given. So we are only taking the last two questions. Thank you.
Thank you so much, Chair. My name is Charles. I want to appreciate all the presenters, and I want to make a comment on the vaccine, the COVID vaccine. Borrowing from the experiences that we have seen on the ground, in my opinion, it is high time that government takes a good ear to the dissenting voices. Where is the myth finding its strength? Because we cannot address until we find out where the myth is finding the strength from. Is it from history? It is not only P7 livers that have this myth. Doctor, very many people have these dissenting voices. And I'm happy that in the beginning, I think you said this is a voice forum. I would rather ask the government to create more platforms to hear this myth and strategically engage with the people and say, okay, these are the myths about the vaccine. And this is how we are going to, this is how we are addressing it. For example, people are saying the vaccine will change your DNA. If that's the myth, we need an empirical evidence. Can you have volunteers? If I were the one, I would have taken, okay, we have research institutions. Can we take samples of some people? We do the study, provide research to prove that this myth doesn't hold water. Otherwise, we are running around, we shall keep coming, radio talk shows, but let us have forums to address, to listen to the myths, the dissenting voices, and respond to them effectively. Otherwise, all categories of people have the myth about, and not only in Uganda, this is a global myth, which needs again a global response, but we can start here in Uganda and say, for us, we want to address it based on the community or local context. And we see how to objectively address this myth. Otherwise, I want to thank God so much because we imagine this forum, if we had some engagement about the myth with the communities, with all the categories of people, and we talk to them, we shall have more converts on this vaccine by using those who have been converted. And I believe that we shall succeed as a nation, as a community. The fight, the other thing is an integrated approach to development, to health and development. I am grateful that we're talking about the parish model. Do we have the voices for primary health care in that parish model? Can we use it as an opportunity? Can the government adopt an integrated approach to address the community issues using one model that's integrated in nature, that will address health, education, economic issues, and everything around humanity? That is my call. That's my prayer. Thank you.
Thank you so much. An interesting way to look at it. Do we give the myth audience? Do we unpack it? Don't we risk the myth becoming reality? The last comment, please.
Yeah, thank you very much, members. I'm called Burlington Pongwej, the Secretary Health, Gulu District Local Government. Members, looking at the challenges that we have been seeing in the different presentation, above all, the problem of infrastructures in our different health facilities. I would like to recommend this in this assembly, if it could be bought, that why don't we think of requesting every partner in the region to invest at least 25% of their project funds into infrastructure and other tangible assets in our health facilities, so that we see a lot of changes in the structures and then the equipment and other things in our facilities. I do recommend that if it could be bought, then let's put it as the recommendation of this assembly. Thank you very much, members.
Thank you so much. I hand over to our panelists. I'm hoping you've been jotting down. We can start with the commissioner, then James, then Hillary, and then Mabel if you are still online and want to contribute something. Quickly, please.
Yeah.
The coupons are already out.
Thank you, Chair. I want to appreciate the participants for the issues raised. I hope I'm audible enough. I'm now much more audible. Or I remove the mask a bit. Okay. I will start on the issue of licensing. Indeed, this is a policy issue to be addressed by the various regulatory bodies. That is Uganda Medical and Dental Practitioners Council and the Allied Professional Council. I take note of this and I'll draw the matter to their attention. Regarding the challenges and the issues which I did not ably address on the recommendations, I think in addition to what I said, the following recommendations are very pertinent. One, government needs to fast track the implementation of the pay targets as stipulated in the pay policy for the public service. Two, government needs to invest more in the health sector in order to improve service delivery to its citizens. Three, the Ministry of Public Service needs to complete the restructuring exercise in order to make provisions for absorption for specialists, super specialists, and all those who have attained additional qualifications. Four, we need to invest more in training and capacity building. And I want to tell you that on a good note, I'm trying to engage finance this year through my permanent secretary to make a provision for additional 7.5 billion for training specialists, super specialists, including nurses in key critical areas such as intensive care medicine, ICU, neonatology, just to mention a few. And lastly, we need to divorce politics from professionalism. This is killing service delivery, both in central government and even in the local governments, where people are given jobs as a reward and not based on their abilities to deliver. I hope you don't quote me. Regarding the payment of COVID allowance, this is an allowance which was cleared by Minister of Public Service, and it's paid to all frontline workers who are involved in the management of COVID-19, but dependent on the level of risk. For very highly risky ones, risk areas like those working in the ICUs, they are paid 80,000 per day. For the moderate risk, it is 60,000 per day. And for others, it is 50,000 per day. But I want to tell you one thing, that this allowance is only paid to health workers who are deployed and domiciled in gazetted ICU. I mean, in gazetted CTUs, COVID treatment units. So if you are not a gazetted COVID treatment unit, like Gulu Regional Referral Hospital, it might become a challenge to pay you because of the numbers. However, it is a matter that can be looked into. Regarding demand-driven training, I think we need demand-driven training coupled with proper human resource planning, which addresses clearly the issues of succession planning. And I think, again, this is an area where government has a huge gap. We should be able to forecast that in the next 6 months, how many human resources will be retiring from the public service, and adequately identify the suitable replacements. But unfortunately, there is a tendency for us to relax on this, because probably we have our own perceptions, and at the back of our minds, we have already identified the replacements. This must be done properly, and I entirely agree for the need for this. Regarding the absorption of those who have completed training or those who are currently attending training in various institutions, the matter of the absorption will adequately be addressed in the in the new structures for the health facilities, which are provided for additional positions. For example, at the district hospital level, we now provide for all the specialists in the 4 disciplines: obs, gyn, pediatrics, surgery, and medicine, in addition to community health. So those who complete the training, we hope they will be absorbed. Regarding the maintenance of equipment, I think this is a matter beyond the office of the director. It's a matter that needs to be escalated to the Minister of Health headquarters. We shall draw it to the attention of our infrastructure department to ensure that they are felt on the ground. They don't just come, enjoy with the director in the hospital, and then leave other lower facilities unattended to. It is something we take note of. The gradual promotion and motivational system, similar to that of the UN, we take note of this, and I think we shall borrow leave. Unfortunately, again, promotions in the public service are not automatic. They are based on your ability to perform up to a certain standard. And just briefly to comment on the UN system. The UN system is premised on clearly well-defined outputs, which are very measurable. You know, at every level of service delivery, you're properly assessed. And I think government has to borrow a leave in that. That's why growth in the UN, it's very easy. If you deliver, people recognize what your contribution is to society, and it can easily be measured in terms of outputs. But now here, I'm told now you have the clock in and the clock out system. I can go to Gulu Regional Referral Hospital. I clock in the morning, then I walk through the gate. I go and start doing my own things, and I clock out in the evening, and I get my pay. It is something that is very serious. Yeah, lastly, the linkage between health department and other departments such as engineering, okay, we take note of that. Why should assistant DHOs be on U3, ignoring other qualifications? This matter, we have resolved it in the new structures. Thank you very much.
Thank you so much. James, please. Hello? I give you this.
Thank you, ladies and gentlemen. I actually rarely address people while seated down, because in my culture it is in discipline to stand in front of elders and you sit down and address. I rarely do that. Even my own staff, I stand up, even if it is a question time. They can attest to it, they can tell you. Mine are mouthful. To my body chair, I think I brought in the issue of HR just to make sure we blend it well. It was not in bad faith. How frequent is this done? This is a quarterly activity, which we do quarterly, and there's always demand for it. That means the facilities generate through job cards these demands, and then they do the what? They do the maintenance. I think this is I'm trying to amalgamate the questions and the answers. And maintaining equipment starts with the respect for the equipment. Imagine if you don't respect your gun, you come with it and just put it in the sitting room. The children will cock it and fire it. When a medical equipment is given to you, it is some of these equipment are even 500 million, others are in billions, like the X-ray machine. You must first respect that machine before even touching it. So then maintenance starts with the people who use it. Why is it that when you go to an ATM machine, you are so careful in pressing the PIN numbers? When you are pressing the same on an X-ray machine, you even come with blood and soiled hand. Even the force of pressing it. So there must be discipline in handling equipment. So the maintenance starts with you, the moral maintenance starts with you before it can come to us. But otherwise, this is done through those job cards, and some of these job cards are signed by the DHOs or facility in charges, depending on the level. I want to answer something about the issue of the risk allowance to Lacho. I think we need, as a region, we need to still think about it and see how we can present it and this should go through the board really. As a regional manager, as a regional player, I think we need to think about that. We can do it on a case basis, but that one can be handled. About the testing, others test positive, and then after that, they test negative. These algorithms depend on the sensitivity of the test. And then 2, the storage of these materials for testing. And then 3, the professionalism of the person who is testing. Research has shown that samples collected from the nose, deep in the pharynxes, tend not to give a very good yield of sample, other than taking it through the mouth. Then also, the viscosity of the samples collected. Remember, this test here does not have a buffer. HIV has a buffer. And if somebody collects thick mucus, it will not work. So the skills of collecting and so on. So it is understandable that this comes out, but this is already explained by research. We need to do tests until we really prove. From rapid tests are just screening tests. They are not confirmatory tests. From doing rapid tests, we go to PCR. PCR is the one which must confirm, and it should be the one to confirm COVID. Even if you test negative for rapid test, well and good. If we don't have enough materials, we can stop there, which is good enough. But if it is maybe you are going for an operation or what, we will need a PCR test to confirm that your negative is true negative, not false negative. Though we are more worried of false negatives than the false positives. I've talked about the M&E, supervision of medical equipment. COVID-19 vaccines, the myths, it's true that we are not going far in communication, risk communication about the issue of COVID vaccines. But I think also our near memory, we have lost our closest memories. That when we were growing up, there were isolation wards, there were wards for measles, there were wards for polio, there were wards for what else? These communicable diseases. Now, because people no longer see these wards, they have forgotten that vaccination is good. Vaccination still remains the best public health tool. You will never change from it. Maybe science can leave you behind, but disease and science will always move forward. The unfortunate bit is the social media. The reason why I brought P7, I wanted to lower the bar to very low bar, but even PhD holders, they eat banana peelings on the highway and throw on the road. You have seen doctors, even after drinking mineral water bottle, they throw in the compound of the hospital. So really, the reason of using P7 was to make it look so bad that otherwise I would have just said there are health workers who are there are health workers who are decampaigning vaccines, and this is a person who got an E in biochemistry. If you want us to discuss it deeply, we can do it. We can go into deep science. Enrolled nurse talks about vaccine. What does she know about vaccine? Nothing, apart from injecting. Yes. Vaccine is a very high science. It is not a simple science. Go and read and understand the science. Then you come out and talk what you want. But social media is social media. It's one of the tools of the 20th century, which we are going to regret. The other time a Gaga bus was burning, those days we would run and look for water and pour. But these days people are happy taking the photo of a bus burning. An accident, somebody has lost their head, the head is not there. People are happy recording the accident or how terrible the accident is than collecting and covering the head of a dead man. Isn't it? So we are not going to run away from social media. We are not going to fight it, but we can only dialogue with it. Because if you try to fight it, it is worse. I remember one time I talked about this boy called, this small boy who is singing. Sweet what? Fresh Kids. I told in social media, this boy is supposed to be under instruction and in class. I had over 4,000 abuses, but I've not died. I'm here today. And some of the people abusing you don't even write proper English. The typology is so poor, so we cannot run away from it.
Thank you, James.
And I think I will not go further than that.
Thank you, James.
Those are all, let's stop there. Thank you very much.
Thank you, thank you, thank you. I was nervous about you getting up. Yes, I think you answered all the questions rightly. I see Hillary is ready. We're running out of time. Please keep it brief.
Okay, thank you, Chair. I beg to sit in the interest of time. First of all, I want to appreciate the comment from our emeritus DHO. We appreciate that commendation on the work done. And also the comment on COVID-19 was answered by the Commissioner, so I will not go there. I saw one, I think one or two questions for the PNFPs. I hope I'm loud enough. Yes, for the PNFP, the question was on sustainability. And so throughout my presentation, sustainability came up as a key area that we are trying to address. I must say that there is no one special intervention that will fit all, but I know that there are a number of interventions that are taking place, including some of those that I already mentioned, at different levels. I must say nationally, I showed evidence that the government is stepping in to provide PHC, and this is increasing in amount, which is a good thing, and we hope it will go higher. But we know that we're also having support from the international agencies, like the work that LSDA Rights North Acholi is doing with funds from USAID. These funds are not meant to be there forever, but to build systems. And we always tell facilities that this money may not come forever. And so for the time that it comes, please use it to build your systems, not to be extravagant, but to use the money to build your systems and such that you're able to stand when the resources are gone. But I must also say the district is also playing a big role, because sustainability is not only about money, but it's about technical support, oversight, and supervision, and the districts are doing a very good job in terms of that. I made mention of the community health insurance and the RBF. Again, thank you so much, Annabelle and all the other players that are coming in. This is helping, but this is supposed to build a system. And sometimes if we move away from that and have a mentality that this is money for taking away, then we lose the point in terms of building structures for sustainability. And as a bureau, we do support capacity for management, because we know this is important for sustainability. But we also want to recognize the role of the churches, the religious leaders, the different dioceses that are inputting to this facility. So all these resources that are coming together, it is up to the management of the facility to see how do we use, and the oversight of this facility, how do we use this resource? If they're giving us money to recruit 40 people, what are we going to do with these resources? Will it be there forever? How do we win off? And there are some projects which don't replace stuff that go away. And the reason for that is that you absorb them. And so if you look at them the right way, it will help you to be able to get sustainable. I will attempt to mention one, to respond to one, and that was about investing 25% in infrastructure. We know very well that when this money comes, it is literally pre-assigned. So they've told you you're going to do health system strengthening, you're going to do support direct service delivery. So most of these funds are already attached to a particular need. Though we do look out for people who support infrastructure development, like I already demonstrated, we have some funds coming in for infrastructure. Thank you, Chair. Back to you.
Thank you, thank you. I'm being told to close. I don't know whether Mabel is online. It would be unfair not to give you a chance. I can't recall any questions that were directed specifically to you. But if you had a last comment, we need to wind up. 1, 2, 3. I'm not hearing anything from Mabel. I want to thank everyone. It's been a good discussion. Lots of feedback, thoughts, recommendations. Looking at on the question that was posed around the myths on COVID, and also the issue around those who the repeat positive testers. I was trying to see how we can either have a campaign to allow our people, to support our people to use social media, to use internet positively. A lot of these questions that are posed actually do exist on the internet. The answers are actually on the internet. You might be surprised that these are not very unique cases to Uganda. So let's use the opportunities we have to engage, to train, to support people to use social media and also available internet channels positively. Thank you so much. Another round of applause for the panelists. And I now hand over to the MC. I can see he's so impatient.
No. I'm not impatient. Rod here is saying that there's one thing he wants to get an answer for. There was a question, I think, that was asked about drawing blood from drunkards, something like. He says he wants to get an answer for that one.
Yes.
Let me accept.
The last one.
Ladies and gentlemen, I think that was also a social media issue. I talked about it, I think on the joint review the other day, that that was irresponsible media reporting. And if indeed it was created by 93.3 KFM, Ministry of Health should take it up and sue 93.3 KFM and probably ask for about 100 billion from it so that we can use that money for finishing our staff houses and so on. It is really irresponsible because we pick blood irrespective of your status. So long as we have assessed you, you can donate blood. Then you become a donor, isn't it? We don't know what you do in the night. We don't know what you do during the day. But still, we go ahead and collect blood from you. Now, after the scenes, behind the scenes, we go and check this blood for HIV, we check for hepatitis, we check for other parameters. That is when we now begin isolating that this one is not fit for transfusion, this is fit for transfusion. We even take blood, even if there are parasites in it, malaria parasites. But I think let's be very careful that we don't throw bloods from drunkards. That's a very big lie. In any case, alcohol stays a few hours in the blood. It is broken down completely. So it is a little bit irresponsible media behavior. And those are the kind of things we say, Commissioner has already come up with it, that they need to go on an issue of legislation. It is very important. We did it during elections. We switched off everybody, and people beat their chests, but their chests did not open. But for the health misinformation or disinformation or bad information, I think it's not right. But otherwise, that's the basic fact. Thank you.
Thank you, James. I think we can retire the panel. MC, should I hand over and you give us the program for lunch and afternoon? Please go ahead.
I want to be sure that you've also finished. as chair. Thank you very much. Ladies and gentlemen, a round of applause for yourselves. For your chairperson, the chief of party, and to the panelists, thank you very much for your information. Just very quickly before we go for our lunch, we'll basically come through the main data, the main point of it all. After lunch is basically trying to wind down and close our assembly. But before that, lunch is at the same spot like we had yesterday. That is if you were here yesterday. But if not, follow where the crowd goes. Number 2, lunch is by invite only. That means you must have a coupon with you. And if you haven't received one, you can approach the desk, but it has been distributed amongst us. Number 3, we shall be back here exactly after 45 minutes. That means 2:15. We shall be here, and all of us are here for plenary. We can divide. If the space is full here, you can go to the second hall, because the feed from this hall is going to go to the second hall. But it's going to be a plenary where we have a presentation from one of our commissioners from the Ministry of Health, and thereafter they will be reading out of a draft memoir from one of us. Then we shall plunge ourselves into the closing bit of it all, okay? I want everything to end by exactly 4 o'clock. So let us keep time. 45 minutes direct on the dot. We shall be back here to start at 2:15. Hello. Good afternoon, ladies and gentlemen. Good afternoon again. Our first annual regional health assembly for Acholi sub-region is coming to an end. But I also believe that in your minds, individually, you're grading us as per the success of what we have achieved so far, based on what you have seen, your participation as participants here, and even for the organizers themselves. And like any other score, you cannot get 100%. But at least you can get above the pass mark, isn't it? Whether you put your bar too high, I am very sure the team has surpassed it. Okay? So the success of this comes to all of us. For the afternoon session, like I said, time is always of the essence on my part. I would like to invite everyone, including those in the other room. This is a plenary, and we are going to continue into the closing session as well. The chairperson now is Miss Agnes Kawaicha from Enabel. I hope I pronounced that right. If it's not right, then it's the mask, I think. Miss Agnes is our chairperson now, and we are going to have a long plenary presentation by our Commissioner for Community Health in the Ministry of Health. Chairperson, please take the floor and introduce our speaker.
Thank you, Mr. Moderator. Good afternoon, everybody, and welcome back from lunch. Hopefully you had a very good lunch. We are well energized, hopefully not tired after having that very good lunch this afternoon. We turn to a very interesting story this afternoon, community health. And before us this afternoon, to give us this presentation is Dr. Upenso George. Doctor, before I give you the chance, I'll first give him a thorough introduction and also a good introduction to the subject. Ladies and gentlemen, you know very well that a lot of things happen in the community. It is in the community where malaria bites. It is in the community where hunger. It is in the community where we lack water, sanitation issues are common. But then, as health officials, we leave it to the community health workers and the VHTs. Yesterday you could hear that for us in the community we are very vigilant. Once the medicine comes, I will rally all my family, will go and get the medicine, we'll keep it. So in most cases we are keeping even the medicine in our houses. And yet, at the end of it all, you're saying we are having the issue of drug stockouts. Now, it is at this point, that health officials, the health sector, no longer needs to ignore the community, and we are calling for attention. Distinguished ladies and gentlemen, I want for purposes of this community that we are no longer recipients of health services as communities. We have become more influential in assessing our environment. We know our health conditions and needs, and therefore we call for more collaboration, participation, dialogue from you. The pandemic, the COVID-19 pandemic made it even to our advantage. This is where the cases were being noticed. We did the prevention, were asked to do home care services, the surveillance, the detection, and all the logistical support. So the role of community should be brought to the forefront, and new models of health service should be sought out. And it's basically what Dr. Upenso is going to tell us this afternoon. And yesterday, many people were talking about the government of Uganda parish development model, which gives us also an opportunity in terms of bringing services nearer to the people. So this shift of the ministry that is going to be provided this afternoon by Dr. Upenso is going to highlight the new approach, the new agenda, the new era that the Ministry of Health is putting across in terms of engaging the communities more. So without preempting your session, Dr. Upenso, Doctor is a seasoned public health consultant, and he has done this for 16 years. Currently, he's the Commissioner of Community Health at the Ministry of Health, and he has been at the forefront of this at the Ministry of Health for many years, sometime. Ladies and gentlemen, you will allow me and join me welcome Dr. Upenso give us his presentation this afternoon. Dr. Upenso, you're welcome. It's there, okay. As he walks to the podium, he has 30 minutes, strictly 30 minutes, and according to the timetable, I don't think we have questions at the end of it all. Please, you can slot in if you have a remark, if you have an addition, you can slot it in, and I'm sure he will address it. But also our members on the virtual representation, please feel free to give in your comments, and they will be addressed. Yes, you're welcome.
Good afternoon, ladies and gentlemen. Chair, thank you for allowing me to stand up, because if I had remained seated, people would think the voice is coming from under the table. But also for giving me the opportunity to stand on this existing protocol and recognize the presence of both the dignitaries in their respective capacity. And also, allow me to say that you properly put on your mask so that I can remove mine, so that you don't lose this beautiful voice. This is the only My presentation is going to be premised on Uganda Community Health Agenda. But that is the priority for community health in line with the Ministry of Health policy. But here we are supposed, as this region, to draw up our own agenda. Having understood which line is Ministry of Health going to toe, I took this line. I don't know why they are not projecting my presentation. I took this line for reasons that when I was asked to come and present, the presentation was supposed to be updates on community health. I said, that is not strategic. I need something which is more strategic, especially when we are looking at trying to improve key health service indicators for this region, as we look at the health of the community, including health of the refugee population. And so push me to the next slide. That is the outline of the presentation. You all have eyes, you can read. Next slide. Let me give you the introduction to this. You also know that Ministry of Health is getting away from what we used to call health sector development plan. We are supposed to come up with a new health sector development plan starting this year. That has been put aside because NDP has taken that role. And so in line with NDP 3 aspirations, Minister of Health has also now embarked on the development of a national health policy, which is actually going to be the third national health policy. And also to operationalize that, we are also going to develop what we call the Minister of Health Strategic Plan, which will run from 2021 to 2025. And all these will be aligned to the Vision 2040, the National Development Plan, the Human Capital Development Program, and Program Implementation Action Plan. Those are the areas. Next slide, please. Okay, go ahead, it will come. Press the button, please. I want to give you what the community health agenda and priority for 2021 looks like within the national health policy. And now, this community health agenda and priorities for Uganda in this new health policy, okay, will come out from two key policy objectives. And these policy objectives are up to, I think, 9, but the one which addresses and speaks to the need of the community population are policy objective 3 and policy objective 4. Policy objective 3 says to build household level and community level demands for services. That is where we are going. Policy objective 4 says strengthening the resilience of health system and community to withstand public health challenges, policy initiatives, and implementation strategies. Now, I want to unpack for you these policy objectives, especially starting with number 3, which says to build household level and community demand for services. Inside there, 3.1 will say the sector shall strengthen health promotion, environmental health services using traditional and innovative methods such as community health workers, the ones you are referring to as the village health teams. They will strengthen methods like outreaches, mobile phone use, and other traditional, methods for reaching the community. 3.2 says the health sector shall broaden partnership and meaningful engagements with health promotion stakeholders to implement community health programs, prioritizing social determinants of health. Because we believe that health is not just absence of disease. And for over the years, we had transformed our ministry into a ministry of diseases and want to run away from that. And that's why you see in the ministry, there's a commissioner for syphilis, commissioner for TB, for HIV, commissioner for malaria. We don't want to continue in that direction. And we are saying, vital to this, that is inside that, please go back. Vital to this, please go back a little. Vital to this shall be to increase access to inclusive safe water, sanitation, hygiene, with emphasis on increasing coverage of improved toilet facilities and hand washing practices and prevention of non-communicable diseases. Examples of the non-communicable diseases are mental health, healthy diets, regular exercises, addressing mental health, including tobacco, alcohol, and substance abuse, preventing death due to road traffic accidents, etc., etc., etc. That is not to say end of the thinking capacity. I'm saying all those people who spoke before me made mention of these as issues which demand attention and shall broaden partnership and meaningful engagements with health promotion stakeholders. And if we are there a partner and you are listening to me carefully, I am actually presenting you over to these people in this room to start engaging you. I will not wait for the power to come back, but I will continue because I'm still digging deep into objective policy number 3, which is talking about to build household level and community level demands for services. We have 3.3, which says the sector in collaboration with the urban authorities, knowing that Gulu has become a city. And we are saying, in collaboration with urban authorities, shall develop and implement the urban health strategy with special focus on mortuary services. DHO Emeritus said he wants a mortuary where he can go and sleep comfortably. Public toilets and poor population living in listed and unlisted slums, other vulnerable populations such as the homeless, the street children, construction workers, sex workers, temporary migrants, etc., etc. I am listing all this because you will realize that as we move towards 2030, where universal health coverage has given us targets, and I've said, leave nobody behind. We want this policy to address all this. Now, 4.4, objective policy number 4, which is talking about strengthening the resilience of health system and community to withstand public health challenges, policy initiatives, and implementation strategies, speaks to this demand for community in this direction. 4.1 says, the sector shall establish robust community health systems in order to reprogram towards primary care services and community-based service delivery. For years, our direction has been build a hospital in every district, build regional hospitals in every region, build national hospitals wherever. But there's no country that can build hospitals for all the 42 million people, for example, in Uganda. And you cannot have doctors, nurses for every individual member of the society. And so we are saying our direction is that we must establish what now we call community-based service delivery systems, which is resilient. 4.2 says, government shall institutionalize registration of all households and particular target groups such as pregnant women, to provide targeted health education and strengthen continuity of care using community health management information systems, and provide health cards for linking to primary health care facilities. Listen carefully. The labs we are talking about is something to anchor into this and help us digitalize this kind of innovations we are talking about. 4.3 is saying the Ministry of Health, local government, and city authorities shall empower the public health cadres so as to address social determinants of health effectively by continuously raising awareness and enforcement of Public Health Act. Yesterday, His Excellency the President in his speech said we shall even amend this Public Health Act so that it speaks to the need of our population. And that is to tell you that now it's not going to be Ministry of Health business as usual. In this respect, we are actually trying to transition and decentralize services to district local government. And this is going to be the first time we are beginning to see health system or health sector is actually properly decentralizing. And so, what is Minister of Health position on community health agenda? I've tried to give you the policy direction, the policy shift, which was mentioned in the earlier presentation by one of the keynote speakers, that ministry is actually taking a shift towards community health. Okay? And I want to borrow again from my senior, the director of Gulu Regional Hospital, when he said, we need to re-engineer our policy. And this is one of the things we want to re-engineer. And so the priority of Ministry of Health, okay, is this, that Ministry of Health will prioritize 2 health service delivery platforms. One is the community-based service delivery platform, which will look at delivering service within the confines of people's homes. That is community-based service delivery platform. The other service delivery platform is the facility-based service delivery platform. And mark me here clearly that time and continuously we shall talk less about health center tools. The president in his own speech said, Minister of Health must now recruit doctors and put them at health center 3. And when they're at health center 3, they will be seated there to wait for referrals that will come from the community. That means there will be no health center 2s because we are upgrading all the health center 2s to health center 3. I want you to look at that vacuum between the health center 3 and then the village. The intention here is to build a community service delivery platform, okay, which will act like a health center 1 and looking at the village health teams. Yesterday again, the president went ahead and said, we need to reinvigorate the village health teams. Said, go ahead and give them refresher trainings. He was talking in line with the home-based care, but that is to ride on COVID. Going beyond COVID and after COVID, we are going to have a health center 1 that is run by the village health committee. And that is the direction because the village COVID task forces will transition into the village health committee to do for us all those activities. And you remember the roles of the village health teams have never changed. They have been in ICCM, and that means they're already taking care of malaria, pneumonia, and other diseases from home. We have designed for them programs for nutrition, and it will be called community nutrition. TB is already calling it community TB. HIV has already reached there. But you also know that palliative care services for cancer patients whom doctors say, now for you, go and continue from home, is already within the confines of people's homes. We just want to actually build this, integrate COVID into this, and home-based care is complete. Let's move to the next slide. Just stop there for a while, because I want people to begin to appreciate what is these community health systems we are talking about in Uganda. And the community health system in Uganda is strongly interlinked to overall formal health system. And at the national level, you all know that formal structures are in place to oversee, to govern, and to supervise. But as Uganda's health system is decentralized, now that's where we are. As it is centralized, you must begin to think, how then does this speak to our needs in this particular joint review mission? So as Uganda's health system is decentralized, implementation and management of community health services will be conducted at the district and at lower levels. When we talk about the districts, we are talking about the health sub-districts, we are talking about the sub-county parishes and the villages. For us, we have taken advantage of COVID and decided to go straight to the villages and establish the village COVID task forces. On the 20th of October 2020, the Prime Minister of Uganda, that was the Right Honorable, that to every cow, every LC5, every RDC, include DHOs, with immediate effect establish village COVID task forces. You never knew why it was being done. And immediately, a letter from Permanent Secretary, local government said, if you have formed a village COVID task force, send to me all the names of those people who formed the village COVID task forces. And that was done. I'm in receipt of very many of those, submission from you people, how you have formed the village COVID task forces. I'm saying this to answer and address the concern which was raised at the beginning. How shall we functionalize all these village COVID task forces? How do we then take advantage of the parish development model to make this work? I will reach there and I will let you know, because that is our thinking, okay? And so each district has a health department which has the mandate to plan and implement health services in their respective districts. We will be at the ministry giving you guidance, sitting back and watching how you do it. And when you call us to come in this kind of performance review, we shall tell you and educate you how you would have done it better, just like other districts or other regions are doing. And you also must know, next slide please, as you will also remember that community health workers, the ones we call the village health teams, and other critical community resource persons exist, and they exist everywhere in our districts, and including but not limited to health assistants, community development officers, disease-specific community health workers. For example, the TB call theirs linkage facilitators, the HIV people call them expert clients, some others in COVID call theirs case management or case managers. All these are community resource persons, which we must begin to think to leverage upon. When we talk about community health services, all of you who ascribe to community health, you become community health workers. And I'm actually a chief of village health team in the ministry. If you want to clap, please clap very well so that I can enjoy. Having clapped, I want to tell you, ladies and gentlemen, that communities in Uganda are currently playing a passive role in the community health system, very passive. And that's why right now we are drumming what is called community engagement strategy, and we have decided to put there the home-based care for people to understand how community can be drawn into the community health space, retooled with all the necessary tools for them to perform, and then give them the opportunity for skill transfer. And that's the rollout we are doing. We are doing it region by region, district. The first district to benefit from that is Amoro, like I told you. Amoro quietly received a lot of money and they ate it. No, they didn't eat, they didn't eat. Because of the experience we got from Amoro, Busia, Mukono, and Ngora, we quickly escalated and said, let community engagement and home-based care become the vehicle to bring communities into the health space and begin to participate in health as a right and as a duty. And that's why, like I said before, local government decided to say, let's send money for this project, which we are calling project now, but it's not a project. This strategy which is being tested and being seen to work, to be the one now to drive this agenda of decentralizing health services to the community. Yes, and we are saying that this community whom we are saying are currently on the receiving side. They are on the expectant side and acting solely as consumers, and instead of demanding quality services, this community are actually seated and waiting. In the design for community engagement, we have decided to write to Prime Minister's Office and National Planning Authority to help us modify the parish model to anchor in community health services, so that as they think of empowering the community to have money into their pocket to live a healthy life, we are saying there is no productive population without good health. And so the first thing is let them have good health, and then they can even use the money effectively. So we are in that write-up, and you will get to know how we have leveraged on parish model to make sure that community engagement and home-based care for all disease conditions which occur in the community are actually anchored properly within the parish model. We shall continuously engage and tell you how we have moved. And we want to move from Almata to Astana. And you people know that the Astana Convention of 2018 took place, but before it took place in 2018, in 2017, Ugandans here went to South Africa in big numbers to prepare for what would take place during the Astana conference. So in 2017, Uganda was among the very many countries that attended that conference. The conference was about institutionalizing community health, to make community health become a practice and also a service at every level of service delivery, whether it is at regional referral hospital level, whether it is district hospital, whether it is at health center 2 or 3, whether it is at household. Community health must be institutionalized. And so a number of resolutions were made and several milestones were achieved. And this culminated into what we now call Uganda National Community Acceleration Roadmap. That acceleration roadmap has 6 key priority areas, which I will mention for you. But take me to another slide, because there is something I want to tell people about what we are talking or referring to as community health system. Now, stop there. The community health system we are talking about doesn't leave behind the human capital. And here, when we talk about paying health workers, we don't think about paying the community health workers. When we talk about information system, right now everybody is about how do we make hospitals paperless. You had the commissioner clinical service. When he was asked something about community health, he said, that is not my area. We have for years invested so much in clinical services. And so when we are talking about human resource, we are talking about those ones who work in the hospital. When we're talking about information system, we are talking about what can we use to capture data from the hospital and send to the center. Nothing for the community. When we talk about supply chain, we are talking about how do we give medicines to hospitals, okay? And yet we are saying in home-based care, we are coming with home-based care toolkit. Home-based care toolkit, we have deliberately decided to put it under NMS to also supply, just like they are doing for hospitals. I will tell you what is inside the home-based care toolkit, which we want must also be given to the people at that level. If it is village health team, they must have that toolkit. But we're also talking about financing. We are not going to develop a system for community health and not finance it. Leadership and governance. We have decided to leave community health work, especially the village health team, in the hands of people who cannot supervise them. You heard my director say, we are actually developing even the parish model, but who are going to be the supervisors? We have ignored that. We have relegated it to some people will not even supervise them. That is a point of discussion, and that's why this forum is here, to think through, as a region, is this the best we want? Yes. And so, you all know that community health system, given all those building blocks of human resource, finance, but I want to take you at that level. That even when we are saying we are going to empower the community, we are going to digitalize the community data. Is it a technology that is scientifically sound? Is it socially acceptable? Is it accessible to those individuals and families and communities? Are they able to sustain? Because the cost of implementation, okay, to the country and to the community, is this something they are able to maintain at every stage of their development? We want to go there. We want to go to the community. But what is it that is good for us? I can assure you, we are beginning to implement some of what we are calling community engagement strategy and home-based care in part of this country. But what is applying in that part of the region may not apply to this region. And so what we are discussing here must be what we think as a region we can afford. So, go to the next slide, my brother. Yes, there you are, community health agenda for Uganda. I want to give you the updates here. What Uganda needs as its priority for community health. Go to the next slide. That one, I am not very sure if you can read that. I wish there was a way of magnifying it. But the priority needs for Uganda are broken down both at national level and also at the delivery service level. At the national level, we are looking at 4 broad areas. Area number 1, which is up there, is about system design and policies. The next one, which is lower there, is about community engagement. And then the next one is system management and leadership. And then the last one there is about health products, okay? I will not go into this detail word for word, but I will tell you that at the system and policy, system design and policy level, we are supposed actually to make sure that we have a comprehensive, costed community health framework that includes all systems, okay? Systems with its building block. We have made mentions of the building block for community health. That includes all those. But we must also make sure that we support the development of an enterprise architect to integrate the different health information systems. There are quite a number of details under that, okay? That is about the systems, which will also include how do we support and review the Public Health Act, how do we develop guidelines. That is at that system and policy design level. But at community engagement level, okay, the last bullet is the one I will concentrate on and says we must empower communities to improve. Yes. Where are we? He has disorganized me. I was saying, it says empower communities to improve rapid health response to management of outbreaks and resilience to diseases like Ebola, cholera, typhoid. And that means community which we want to draw into the health space are not only going to look at COVID. We are riding on COVID to make sure even when another epidemic occurs, it finds the community ready and can respond. The system management, now go back a little. Yes, the system management and leadership, we are saying we must build capacity for leadership and governance because we want a community health system that accounts to some kind of authority.
Doctor.
Yes, please.
5 minutes.
5 minutes, yes, thank you. At the service delivery level, the program delivery level, we have also tried to go to the next slide. At that level, we have also categorized the political prioritization. We have also prioritized around recruitment and accreditation of the health workers, their trainings, their supervision, data reporting and information systems, and those are the details under each of those categories. That is the country's need, okay? That is the country's need. Go to the next slide. Go to the next one. Yes. Now, out of the big priority need for the country, we say we cannot move with all that within this financial year of 2021 to 2022. So we came with 6 key priority areas as a ministry, and that's to give you the direction the country is taking, so that now we can contextualize. If this is the direction of the country, for us, if we have already achieved this, what else do we need to do? The 6 priority areas, 1 is to develop a comprehensive, evidence-based, costed community health strategy that includes all community health cadres and other health system components. For years, this country has not had anything we call a community health strategy. All these strategies, we are looking at either human resource capital. If you look at the village health team strategy, was developed in 20 years ago, was talking of how do you bring people from the community to add to the health workforce, okay? That did not work out. We thought of bringing what we call the choose strategy. That did not see the light of day. But here we are saying we want a comprehensive community health strategy that speaks to all the building blocks of the health system. 2 is to strengthen community health leadership, governance, and multi-sectoral collaboration throughout the entire health system. Yes. 3 is to strengthen and sustain, okay, chain across all levels to increase the availability of critical quality supplies and commodities. When we are talking about masks for the community health workers, nobody wants to even listen. At the beginning of the outbreak, all the masks, just simple masks, were only for health workers who are working in health facilities. And we said, if we are talking about home-based care, we are actually taking patients who are as infectious as those who are in the hospital, but stay at home. Then we are sending unprotected health workforce to meet them head-on. 5, invest in the scale-up of appropriate technologies for community health implementation and supervision. You heard about the lab. Invest in the active engagement of communities, and that is the principle of community engagement strategy and home-based care. So in all this, go to the next slide. In all this, I've tried to tease out level by level what strategy number 1 is talking about, that is developing a comprehensive evidence-based costed community health strategy. Those, please, let them see what is on these details here. Those are the details pertaining to that area. At our level, at the ministry, I've already brought on board a consultant procured by USAID, and regional consultations is ongoing to see how do we have a comprehensive community health strategy that speaks to the needs of the community at that level. We even came to Gulu here and sat in one of these boardrooms here to ask the people here, how do you want community health to appear for the next 5 years? When you look at the collaboration, already the community engagement strategy under the technical intersectoral committee headed by the Prime Minister is already rolling out the community engagement strategy at that level. We want to see how every region and every district embraces that community engagement strategy. Under area number 2, strengthen and sustain investment in supervision and motivation for these community health workers. What we have done at a very small level is to make sure that government starts by paying at least 1 village health team person per village. And if you have a parish of more than 12 villages, then you have 12 people being paid in that parish. 12 people being paid in that parish. That's the kind of motivation, and we want to see local government pick it up. We are paid them for the first quarter, which ends in September. We are engaging government to continue with the next quarter until it becomes a routine thing that village health teams are paid. The president, when we presented the community engagement strategy to him, we told him that we are going to start with 1 person per village. He said, that's not a problem. I would have loved to start with the 2, but let's wait if our oil starts to flow very well. Then we'll go to 2, maybe with the time, if Amuru Sugar Factory starts work, it goes to 3, then it goes to 4, okay? But partners must continue supporting those village health teams they had been supporting before. Yes, and I think number 4, strengthen and improve community health supply chain across all levels. We have started with the home-based care toolkit. In that toolkit, we have categorized. We have supplies. Under that supplies, we have the masks, we have the sanitizers, we have the gloves. Under the equipments, we have the pulse oximeter, we have the thermogun, and we have the timer. Under the medicines, we have a medicine toolkit. In that toolkit, we shall add on it medicines which are not under ICCM and will include Panadol, zinc, and vitamin D. Under the tools, we shall put all the home-based care tools, including the registers, the patient monitoring tool, the referral forms, all. And they will all be put in one pack called backpack and will be delivered. We are starting with at least a toolkit per village. And we want to see that when we start with 1, it should increase to 2, it should increase to 3, so that these people are able to reach a home or a household and they said, there is a COVID patient there under home-based care, and they have the necessary tools to look after that person. Yes, under 5, scale up appropriate technology for community health implementation and supervision. The appropriate technology we are talking about now. And here, again, Amoro will testify to that. Now, people kept asking me, why did you choose Amoro? I told them Amoro starts with the letter A. That was the best answer I could give. So Amoro has received a sample of all this, including, but not limited to bicycles, not limited to handsets, okay? You can imagine how we are beginning in a small way, but that is the agenda for this country under community health. We want to make sure that every village district receives that. And we are trying to leverage on what we call intelligent community health system, which is a tool to help all this technology and innovation for data capture and data reporting be on one platform, so that you can use whatever innovation to capture data, but we have a platform. And that's what we are developing now. And the community engagement arrangement is under the home-based care under COVID, which we are trying to implement, and we are rolling out. And districts which have embraced both the community engagement strategy and home-based care, their indicators have changed drastically. I will tell you why our region, Fogulo, or Acholi sub-region, has not improved. It will come if you give me a few minutes after this. Now, don't ask that, where will we get the resources? When we are coming, get me another slide, put it there. There, stop there. When we are doing a landscaping of how this will be implemented and supported, these are the partners we said, for us at the national level, this is what we are going to support. Then at the level of implementation, those are the partners. The UN agency, we said, yes, we are going to do that. They are not going to do it for Uganda. They are going to do it for the population of Uganda. Don't say I'm speaking on behalf of Minister of Health, but these partners are everywhere, including here. I will expose them in the next slide. Okay? So this is at the delivery level, and that is at the national level. So we are not short of resources, but let's leverage on what is already there. What we are doing is now to actually add COVID onto HIV. Now that's the trick. Add COVID onto HIV and get the ball rolling. And so, next slide, please. We are not going to complete this presentation without mention of this community engagement. Now, this is an effort to institutionalize community health, both as a service and as a practice at all health service delivery, okay? For enhancing resilience and innovations for sustainable healthcare service delivery amidst this COVID-19. We want to ride on this COVID-19, but going beyond COVID, and when COVID goes away, it must find a health system which is resilient and responsive. Already, the clinical service, you can say it is becoming resilient because of the very many investments put there. Community health, we are being left behind. But I don't want us to be left in the cold. I'm giving you all this so that begin to rally on this kind of information I'm giving you so that you quickly begin to position yourselves, okay? And this community engagement is actually for capacity building. Next slide. It's for capacity building for districts. Get me to the next slide, because I'm about to conclude, so don't warn me, it is about to get finished. Yes, the focus area you see there, the focus area in this capacity building for districts, we are engaging PEFA and CDC implementing partners to support community engagement and home-based care implementation. PEFA has roots in every village, every home. They know where there is a HIV patient, they know one who is on treatment, they know one who is defaulting, they know one who is, they know all of that. We have said, COVID has also gone following those people you are looking after. We want to leverage on your system to look for these patients, support them whether they are at home-based care or they are in some place, support them, but also give us the data. The second focus area of building capacity for the district is about building capacity of district in community engagement and home-based care with global fund support. You will soon begin to see TASO vehicles changing direction from TB and HIV to COVID, and they will be asking you, where do we support you? The money is available, and we are already in talk as community health department and community health fraternity. TASO has stood up tall and have got that money to support this engagement. I want you to know this so that when you see TASO and they have not come, ask them, we were told by this doctor with a square head that you people are now with the COVID. Where are you? Okay? Yes. And the activity for PEFA and CDC and TASO is to integrate community engagement strategy and home-based care into districts and partners' work plan. They have already been directed by their big bosses that please integrate this into your work plan as partners. The next step is integrate this into the districts so that now it becomes a district response. When that is done, then you are able to do both COVID, HIV, TB, malaria, malnutrition, name it. I don't want to mention jiggers because somebody talked about jiggers is not in our region. Yes, take us to the next slide because that should be about the last slide. The activities we have completed under this arrangement of home-based care and community engagement, riding on the support of PEFA, CDC, and TASO. We engage rights in to build capacity for community engagement and home-based care in the Mbale region. We took over all the 14 districts. We started with 8, but now, last week, we completed all the districts in that region. Now, how do we roll out? How do we functionalize? Okay? I have the blueprint, but I'm disappointed that everybody is coming to say, District A, we want to support your village health team in home-based care. They don't have the tools, they don't have the people to train them, they don't have people to support the district's team to first be oriented for the district to take over. They just run there, do things, and come out. The district know nothing about it. It starts with the district orientation, and then the district teams who then start cascading this until they reach the village COVID task forces. That's how we functionalize it. Okay? We have engaged Right Southwest, and Right Southwest has done everything, including supporting with the home-based care toolkits. That is southwestern Uganda. Uganda Red Cross Society took over the entire Kampala metropolitan, including Mukono. We engaged with the Bela, and they built capacity in the entire Rwenzori region. And now they know how to functionalize their village COVID task forces with all the necessary tools. Now, we also built the DHT capacity for community engagement and home-based care in the districts of Mutukula and Kasesero, simply because they said, for us, we have a unique situation. And we went as a ministry to build their capacity and give them all the necessary skills so that they're able now to run on their own. Now, we are in discussion with the METs and sites. METs and sites are the USAID arm that do all the reporting and data capture for HIV and TB. We are saying we are not going to struggle and reinvent the wheel when already HIV data is more or less the cleanest for all the data we receive. More or less the cleanest. Agalitaku efufu, the baganda coil like that. Without dust. But for the rest, still has dust. Okay? And this was a follow-up on the engagement with the PEFA and CDC to integrate. And we are doing that system. Why don't you come with a comprehensive, integrated, home-based care policy for all these diseases which are looked after from the comfort of people's homes? We are thinking we can start one from here. The people in this forum can start it. Together we can achieve. And so the rollout involves training of district task forces, the DHTs, on community engagement and home-based care, okay? Yes. And all this have been done using the partners. Minister of Health has not given any single money that doctor with a square head go to this district and do this. Partners stood up and said, for us, we are not going to wait for this money you are saying will come from government to do this. We started with the 4, Amoro, Amoro, Ngora, Busia. Now we have reached almost 80% of all the districts. We have not reached northern Uganda. Let me go to that slide, which is going to accuse the people of northern Uganda. That is the one. We have remained with building capacity for the remaining districts, which have not done, okay? And they are supported by rights. We are in discussion with the rights EC, that is for Busoga region. And since we saw they are delaying, actually we are taking their task to take over from them. We are in discussion with Rights North Lango to build their capacity. But the following, IDI that looks after Western Nile region are very silent. Rights North Acholi is silent on Acholi sub-region. You will continue to grapple that you are doing home-based care, you will never improve the data. Amuro succeeded because of what we invested in them. We went there and actually built their capacity as ministry. And then we went to Omoro through SNV. SNV is a Netherlands organization. We built their capacity, and that's why RDC, you see that Omoro is becoming more sexy compared to Amoro. Isn't it? For God and my country, I end my presentation.
Ladies and gentlemen, let's give a very, very huge applause to Dr. Openytho for the interesting presentation he has given us on community health. If you can forget anything, just go with 2. It's no longer business as usual. Community health, we are demanding that we need to be engaged, we need to be empowered, we need to be brought on board because we have a stake in all this. Thank you, Dr. Openytho. Now, I need to be guided. I don't think I had a session for questions. That one will be taken over by the chief moderator. And ladies and gentlemen, I am waiting for the huge applause for the moderator. Thank you.
For the presenter, okay? That was the applause for the presenter, not the moderator here. But you can also give me one. That sounded half of it. Well, thank you very much, Commissioner. Thank you for that presentation. I was advised that it was so important for us to listen to him and we wouldn't limit time, especially for his presentation. So we decided to let it go and roll until he was okay with it. So please, thank you, participants, for accepting that adjustment without your permission, of course. we are coming towards the tail end of our assembly. And before we go towards the official closing bits of it, I would like to call upon the DHO Omoro. Where is he? Yes, he's there. So that he can come and read out the draft memoir for us. It will be about 10 minutes or so. And then thereafter, I will invite the panel for the closing team, or the closing team will take their seats in front, including the road, of course. As you come in, is it on PowerPoint? Okay, good. You do it.
Yeah, thank you, MC. Thought I could call you the chair of the session. Yeah, thank you. I'm called Ngom Robert, the acting DHO, Omoro, but also the secretary to the DHOs in the Acholi sub-region. Once again, the moderator, distinguished delegates in their honored capacities, colleagues, good afternoon. Now, I have the honor to present the resolutions of the first regional health assembly for Acholi sub-region. These were the issues which were captured, discussed, and agreed. But the Secretariat carefully and religiously put the issues and the resolutions in this format. It's a fairly big document of about 20 pages, but in the interest of time, we are capturing the key resolutions for adoption. Okay. Yeah, thank you for sending me out. So let's go straight to the issues. They have been captured under thematic areas. And very importantly, we'll start with human resource for health. One, under human resource, we have, of course, where it is I is for an issue. Then R is for the resolution, okay? So let's go on page by page. Several posts are vacant for DHOs in the sub-region. This was ably discussed yesterday. And there seemed to be no immediate persons to qualify for the position. This was an issue. And the resolution is that all local government to ensure that the posts, that is the district health team, and I've captured some of them there, but of course we also have the senior health educator, should be filled by next year, 2022. 2 is establish the post of the principal medical officer to deputize DHO. 3 is reintroduce, and I think this came so clearly in the course of today, introduce grades within the salary scale as a way of motivating health workers. Even if they're on the same scale, there could be a difference in this, in the amount at the end of the day. Then the second issue under the human resource for health is that the current establishment in the district does not have enough staff. Of course, we are mindful not only the district health office, but also in the lower health centers. And this needs to be reviewed so that the provided wage bill under primary health care wage should be fully utilized. And the resolution is that local governments, to ensure that 100% utilization of the wage budget, and recruitment should prioritize technical staff across the board. Second is the Ministry of Health to expedite the process of restructuring. You're aware that it started at the highest level, and the desire is that they should quicken it to the lower levels. Another issue is that unfilled posts in the current establishment, despite it being inadequate. And of course, we are saying that local governments, Minister of Health, of course, together with Minister of Public Service, to complete restructuring. Then to local governments to ensure full utilization of, again, the wage under primary health care. 3 is that Gulu Regional Referral Hospital, which should be providing an oversight and a supervisory role to the district health services, to declare existing consultants, specialist posts to the Health Service Commission, and ensure that their entitlements are adequately budgeted for and provided. Another issue still under human resource for health is that many health workers are absent from their duty stations without permission. I think we had this yesterday when we were having the overview of the health status of the region. And we're saying, again, as a way of addressing that we need to have performance contract, not only up to U3, but should go up to U7. Move on. Another issue is newly recruited health workers lack certain skills, and we have 2 resolutions under that. One is local governments or districts to prioritize in-service training, especially in the interpersonal skills, communication, emotion management. Those are very critical for health workers. 2 is the Ministry of Health, of course, with the Ministry of Education and the National Curriculum Development Center, should review and strengthen adherence to the curriculum. The other issue, still under human resource, is some health staff or staff in the health sector, as the hospital administrators, the medical records, or the health information assistants, did not benefit from the health or the salary enhancement, yet they are part of us. Move on. May have to use is that the district health management teams should strengthen medicine management committees at all levels so that to ensure proper quantification, timely ordering, restocking, prescription, and storage. I think this was discussed thoroughly yesterday. Then 2, Ministry of Health should increase the percentage allocation, especially for Health Center 2 under the medicine budget. And for our situation, especially that they are not benefiting under the result-based financing scheme that Health Center 3 and the other higher facilities are benefiting from. 3, facilities be required to maintain one stock card for supplies obtained through the credit line and RBF funds. There is another issue under essential medicines. One is no medicine stores and technical staff, especially the dispensing staff for Health Center 3. Now that we are looking at even introducing a medical officer at that level, would also need to appropriately get the technical staff, especially for essential medicine and the related supplies. The resolution is that local governments should prioritize the constructions of stores, medicine stores, because they require specific conditions to ensure that the medicines are safe for use. And newly upgraded health center 4, some of them also lack medicine stores. But of course, in the meantime, these facilities could use the nearest health facilities, especially health center 4s, to support them in their storage. Of course, documentation will need to be enhanced here for purposes of accountability. We have another issue. Some upgraded health centers do not receive medicine which is appropriate for their scope of services. They were Health Center 2, now the Health Center 3, but they continue to receive essential medicine, the package for Health Center 2. And here, the resolution is Ministry of Health to review medicine allocation and ensure that all health centers have an allocation that is commensurate to their level. I think local leadership, the respective district leaders and city leaders, national medical stores, to ensure that facilities that reject these supplies because of the short shelf life get replacement during the cycle of rejection, because once it is rejected, does not imply that they don't need those supplies. Then we have clinical guidelines developed in 2016 are now outdated. The resolution is that the Ministry of Health, I think with a matter of urgency, to update the clinical guidelines in this current financial year. And this will support the clinicians and health facilities in managing our clients. It's an important thematic area which has just been presented. That is community involvement. And the number of issues here, since we are moving towards a heavy reliance on the community in ensuring a health service delivery or quality health service delivery. One is, and I'm happy that the chief VHT at the Ministry of Health is here and is a strong advocate for this, that VHTs are poorly facilitated I think this speaks for itself. We have 3 resolutions under that. 1, but also under the parish development model. 2, improves supervision and management of health promotion and environmental health staff to enable them better to supervise these food soldiers, the VHTs. And lastly, under that, is that the local government Department of Health to actively engage on social media to help clarify the myth and the misinformation. We decried the challenges and I don't want to say the evil, the challenge that the social media is posing, especially towards health service uptake. Move on. Still under that, local government should prioritize selection and training of UMIC. Those are the health unit management committees under the local capacity grant, and UMIC operations under the public healthcare, the non-wage component. D, that is under health financing. 1, which is an issue under health financing, health center tools are not benefiting from result-based financing. Some upgraded health facilities, especially PNFPs, are not receiving allocation that match the new level. I think this is a serious concern. In my district, Opit Health Center 3 is getting an allocation for Health Center 2. Actually, it is only 3.5 million in the whole financial year, and it is offering services for Health Center 3. And we have already communicated this, but it has not changed. The resolution is that Ministry of Health should allocate higher percentages of funds to Health Center 2s under the PHC non-wage, given that they do not benefit from result-based financing, and should ensure that the upgraded facilities receive allocations, again, that is commensurate. I think the concern here is that they should not, once it is upgraded, both the financing, the funds allocation, and the medicine and other supply should be commensurate to the level that they are upgraded to. Then we have another issue that percentage allocation of government of Uganda in the PBS and the IFMIS to facilitate improved management to deliver on that mandate. 1 is DHO office management, issues of coordination, all should be handled under that. 2, DHO's office, health promotion and environmental health. 3, DHO's office, maternal and child health, of course with the neonatal and adolescent health. 4 is DHO's office, surveillance, and very importantly, monitoring and evaluation. I have another issue, absence of recommended charges for services in the private health facilities. This has caused a lot of storm, especially in this COVID era. And the resolution is that the Ministry of Health should support the health professional councils to develop and publicize recommendations for charges in the private sector and improve the regulation of the private practitioners. There's another issue of low absorption of RBF funds. And the resolution is that improve documentations at the facility levels to increase absorption of RBF funds. E is malaria control. Malaria burden is still a big issue in this sub-region. And first issue is low coverage of the long-lasting insecticide nets among the pregnant women and of course children who bear the brunt of the burden due to high malaria. And we're saying, despite the higher number of nets being distributed, the recommendation or the resolution is improve documentation at distribution sites, especially at ANC and the young child clinic. Then issue number 2 is malaria endemicity in the region has moved from stable to unstable malaria, making the region susceptible to outbreaks of malaria. And the recommendation is that medicine quantification, of course with the improved medicine management committees, and the forecasting should consider this seasonal malaria outbreak variation, especially for the lower health facilities, level 2 and 3, so that they can replenish and have a fairly stable supply of these antimalarials. F is maternal child health. This is again a very important thematic area. It's an issue of high teenage pregnancy rates, and this has been worsened, exacerbated by the current COVID-19 control measures. The official statistics, of course, is a tip of an iceberg, but the truth on the ground, which I want to believe you district leaders have witnessed, the situation is really bad. And the resolution we are fronting is that proactively identify and support pregnant teenagers through community sensitization and dialogue. We really need to engage the community, especially the young ones. And 2, incorporate age-appropriate, culturally acceptable sex education and family planning in the upper primary and secondary school to counter this vice. There's another issue of low availability of CMOC services, very important function for Health Center Health Center 4, and a basic EMOC at Health Center 3, yet facility-based maternal and perinatal death remains a challenge in Acholi sub-region. We have 3 recommendations or resolutions. 1 is to conduct technical support supervision with the support from the regional referral hospital to every health center for at least once every quarter. I'm glad that we've been having a bit of this, but if we could have it regularly every quarter, it would help change some of our indicators. 2, the facility in charges to ensure that all maternal and perinatal deaths are reviewed and of course notified, and the recommendations are implemented. I think this will strengthen the maternal perinatal death surveillance structures in the district. Then expedite the filling of specialized posts in the general hospitals. Districts with general hospitals will really need these cadres to help in that front. There's an issue of no updated figures for maternal, neonatal child health indicators, like unmet need for family planning and a contraceptive prevalence, teenage pregnancy, child and infant mortality rates. And the recommendation or the resolution by this assembly is that Ministry of Health and the Uganda Bureau of Statistics should urgently conduct a Uganda demographic and the health survey to update the indices and verified observed increases in the gender-based violence, teenage pregnancy, and of course the early child marriages and other rates, related rates in this region. But this could be done nationally, but will help us in the region. Immunization coverages below, and again, this has been also worsened with the COVID-19 for all the antigens, BCG, measles, and name it. We saw this ably yesterday. And the resolution is that it will resume outreaches, because I want to believe that will be targeted outreaches and daily routine immunization at facility, so that we strengthen this at both the static and the outreaches that we have in our respective districts. G is HIV AIDS program, and the issue there is that they observed an increase in the number of new HIV cases, and the resolution is improved social mobilization for HIV/AIDS control measures, and I think this will tie in so well with the ongoing efforts in concluding the district and the city HIV/AIDS strategic plans that are being developed. Second is a low coverage of percentages of HIV positive women initiated on ART towards elimination of mother-to-child transmission of HIV/AIDS. And the recommendation, and I think this is a strong one, that support accreditation of some selected health center twos, and also the newly upgraded health center threes. In Omoro, we have now 5 newly upgraded health center threes, but they're not accredited. So we are missing out on that front. So we need to support the accreditation, actually expedite the accreditation of health center twos and health center threes that have newly been upgraded. Many children are not adhering to art. I think that also goes to also the adolescents. They're not adhering to art, yet the support system is not good, especially the community support systems. And the resolution is that community health department to conduct home visit to clients who are not adhering in art, especially with focus on the young ones. I think across the region, that area is not doing well, and it's not good. Clients failing on the second line must get drugs from regional referral hospital, saying decentralize third line art from the regional hospital to district hospital and health center fours. Health center fours in a number of districts without a district general hospitals, actually the district hospitals themselves. So I think appropriate support should be given in that respect. TB, low case detection. I think this came very clearly in the presentation that we've had, and in a number of other fora that we've had on TB and HIV. Low case detection and cure rates for TB in the region, and yet it is a region that has been declared a TB emergency, public emergency region as far as TB is concerned. And we're saying, as a resolution, is that strengthen community-based TB dots. Very important. Then improve interrogation of TB serum in the primary healthcare program and prioritize TB-related activities. I think the support to HIV should go hand in hand with the TB because they are cousins or brothers. Yeah, people say others or sisters. Huh? I don't want the gender. Then another issue is the health infrastructure. This is again a very big issue. As Acholi sub-region, nearly 70% of our districts do not have district general hospitals. No wonder a lot of burden goes to the regional referral hospital. This is an area that needs to be improved on. District councils of the affected districts should pass resolutions to upgrade one of the appropriate health center 4s to a general hospital, and this should urgently be forwarded to Ministry of Health for appropriate planning and resource allocation. Move on. Some districts, however, have already done that, like Omoro. Some counties, constituencies, where our honorable MPs come from, some of them don't have health center 4s. They have health center 2s and health center 3s. And the resolution is that districts, of course excluding city council, that have counties without health center 4s, should also pass a resolution approving the upgrade of one of the existing health center 3s to health center 4, and likewise this should be submitted to the Ministry of Health for appropriate planning and support or resource allocation. Some newly created sub-counties also don't have health center 3s. District with such sub-counties should also pass a resolution to that effect, and this resolution should be submitted to the ministry for appropriate planning and budget allocation. Several health facilities still require additional facilities. They find there's a health center 3 is having the general ward, the general ward, and only having 1 or 2 staff houses, and yet health center 3, the staffing level is close to 20. So the number of health infrastructures that are missing in a number of districts. The solution is local government to prioritize construction of additional facilities under their development grants. Most investment by implementing partners are targeting operational areas. Move on. Secretariat. The resolution is implementing partners in the region be required on a mandatory basis to invest a minimum of 25% of their budget in the capital development area. Most of the staff in the health sectors are not accommodated at the health facility. This is very specific on accommodation. Minister of Health to review guidelines and provide for use of modern prefabricated housing unit for health workers, low cost options housings. Another issue, no ambulance allocated to rural health centers. I think this is a very big cry to a number of districts. Minister of Health to expedite operationalization of the regional ambulance center with the toll-free call numbers. I think this is an issue that needs some urgency. There's another issue, that Allied Health Professional Council, insisting on registering different units of health facilities, be ready to register of health facilities already registered by Uganda Medical and Dental Practitioners Council. And the resolution is that these are professional councils to write to Solicitor General seeking their opinion and guidance on the legality of the action of allied health professional councils. Health systems, health sub-district strategy has become outdated due to the increase in the number of one county districts. When it is a district with only one county, one MP or two MPs. And the resolution is that Minister of Health should review and develop a new strategy to replace the health sub-district concept. Another issue is gaps in knowledge sharing between implementing partners and local government. Partners to report on quarterly basis to the local government and annual basis to Ministry of Health and participate in quarterly district health management team meetings in order to facilitate coordination and knowledge sharing. K, though it is coming towards the last, neglected diseases and emerging diseases, nodding syndrome, epilepsy, and a number of other non-communicable diseases are on the rise and a big challenge to Acholi sub-region. A recommendation is that set up functional rehabilitation centers in each district to handle neglected tropical diseases and other non-communicable diseases. That could also be special clinics with enhanced staffing at the health facilities. Move on. There's another issue on COVID-19 situation. The observed laxity in enforcement of the SOPs that have been prescribed and directed by the President, the Minister of Health, have 3 resolutions. 1, strengthen enforcement of COVID-19 SOPs in the region. Mobilize communities for COVID-19 vaccine uptake. I think this is very, very urgent, and the leadership should need to take up on this. 3 is Ministry of Health to include all PNFPs, those are the private not-for-profit sites in the region, on the list of beneficiaries for the COVID-19 risk allowance. Procure and distribute kits for home-based care, especially for our village health team, to support the cases, the bulk of the COVID cases who are managed within the community at home. Ensure full functionalization of the village task force of COVID, because this task force continuously will take on a number of tasks to support the health sector. Co-opt cultural leaders in mobilizing communities for COVID-19 vaccination. Move on. Yeah, session
as a group. You understand that? And then that means they have advised me to let you know that it would be good to also form a committee that would help to refine the document better so that you also follow up on these resolutions with the different stakeholders. You understand that? So that if you can get partners or teams together or to put the finer details of the words that you need to put in place for the ideas that you want to put forward, form a committee, because otherwise it will end up being one of our presentations in our document here. You understand that? So let's get a working team that shall follow up on that as well. Ladies and gentlemen, this is now the tail end. This is the exact tip of the tail, as it were. And many eyes, I know it is warm, it is after lunch, the sun is up, the heat is up, and the eyes were closing. Please wake up. Let us just stand up and stretch a bit, please. Please stand up and stretch a bit. I'm preparing you for your journeys back home. So stretch up, relax, and set your mind to know that we are coming to an end now, okay? But don't forget that what we have discussed over these few days is pertinent to us, okay? You can sit. That's enough. Our closing party, we shall maintain it as you see on the program. Because if we decide to let other people come on board to speak here and there, then all of us are important. We shall all say a word. So please, let's maintain the program as you see it. That means that the chairperson of the MPs for Acholi sub-region chairing this part is now me. Is now me, and I hope it is a blessing in disguise. Then number two, the team, the chairperson of the DHOs, please come in front. And the chairperson of the RDCs, Mego, please come in front. Your remarks will be short, but to the point. And most graciously, I would like to, you can sit on either side because the center seat is for the ROT, the Paramount Chief, please. His Highness, the Paramount Chief of Acholi, represented here by ROT, Collins of Patiro, please come in front. Dr. Kumakech, Jimmy? Yes, please come. He has an announcement. I didn't want to say it myself. Let him say it in a minute. Because when these people start talking, we shall close and go home. Just a minute, very quickly, please.
Thank you, MC. I'm sorry to come for the second time, but it's inevitable. When I came here, I was complaining of some key areas. Like one of them was the issue of transport for the DTLSs and the regional supervisor. But at 2:32, I got a message from National Leprosy Control Program, Minister of Health, from the Global Fund Management Unit, that I should send a list of 4 districts, stroke cities, in urgent need of motorcycles for TB supervision. And they want the list before close of business tomorrow. So on this note, I'm requesting the DHOs, after this, we have a standing meeting, and we agree, because they have stated clearly, we have to state the justification for the need of the motorcycle for that district or city. And on another good note, 27 microscopes are being engraved for the region. I think these are good things, this is good news. Yeah.
Thank you very much, Dr. Kumakech. And also, as we are closing, those of you who are filling the form for reviewing the health package service, please, if you still have your form with you and you've finished filling it in, please hand it over to the responsible officer at the back there. Just briefly, for the closing, we shall have speeches from these 3 persons, and thereafter our ROT will hand over certificates to those who actively participated in organizing this. But ROT, I would like to let you know that here, for these 2 days in the assembly, the first of its kind in Acholi sub-region for that matter, we've had very many people represented here, different parties from the different leadership of the Acholi sub-region. I can tell you that we have had, let me just start, in no particular order, because I'm still going to be an MP later. The Director of Guru Referral Hospital here, as part of the team organizing this. There's also the chair of the board of the Gulu Regional Referral Hospital and also an DHO emeritus with us here. We've had several DHOs from the Acholi sub-region here, about 9 if I count. I'm saying DHOs, acting assistant DHOs and the acting DHOs, I put them all together. We have had chief administrative officers here from the Acholi sub-region. We have had LC5 chairpersons from the Acholi sub-region here with us. We have also had the RDCs represented here with us. Secretary for Health for the districts in Acholi sub-region are here with us. The director and the commissioners from the Ministry of Health, and I must say something about them. So far we have had 8 commissioners in one sitting, other than their own meetings. This is, this is very good, having the Ministry of Health fully represented here with us at that level. And we have also had IPs, the implementing partners here, of their various capacities, with their different leaders and teams with us here. So I don't want to go through them because I will make a mistake of forgetting somebody here and there, and so many other people. So that is the composition of the team that we have. And do not look at this house only. Another 200 or so are watching us and following us virtually as well. So they have been participating throughout at the designated centers in the Acholi sub-region. So we'd like to say thank you very much to you, the participants here, and to those who have been watching around. I cannot forget, of course, the mayor of Gulu City here with us. He was ably represented yesterday, and he has come in person today. This is our mayor, His Worship Okwa, with us here. So thank you, all of you. And of course, Chief, thank you for gracing this occasion in person. Okay? And ladies and gentlemen, when one speaks, we'll invite the other. I will come at the end when I'm guiding the chief on the award of certificates. Chairperson of the DHOs, please. You can speak from where you are. Thank you.
Thank you so much, MC. Your Royal Highness, the Paramount Chief, or Rot of Acholi, the resident City Commissioner, the resident District Commissioners, the District Chairpersons, the District Secretaries for Health and Education, all Ministry of Health officials, all implementing partners, all invited guests, all other civil servants here present, ladies and gentlemen. On behalf of the health leadership of Acholi sub-region, it gives me great honor to speak for the health fraternity of the region during this first regional health assembly. This first regional health assembly has given us a platform for leaders, health workers, and the critical collaborating partners to discuss issues pertaining to the population's health. We have also shared experiences of good practices, harmonized key policy issues, and identified key recommendations to improve efficiency and effectiveness in health service delivery in the current running financial year and moving forwards. Uganda, as we all know, has registered great improvements in the population's health, as shown by the Uganda Demographic Health Survey, the Uganda AIDS Indicator Survey, and others. But the indicators in the mid-north of Uganda are still wanting. The region is currently posting worrying indicators in a number of crucial health indicators, and this is a cause for concern. The little we, however, scored highly in could not be achieved if the support and collaboration from both government and partners were not there. We only need to reduce duplication of services, ladies and gentlemen. That can be a cause of some of the stagnating and even declining indicators. I acknowledge with appreciation the continued support and participation of our health development partners, the civil society organizations, and other partners like the faith-based organizations in implementation of the sector plans. All this support needs to be well coordinated by the districts in the region in order to achieve results. This is the basis on which the district health officers rallied behind the Gulu Regional Referral Hospital Management to ensure we initiate the regional joint review mission sessions. This is the first of its kind, whose idea was mooted by the DHOs of the region. And I take this opportunity to appreciate so much the apt overall leadership of Gulu Regional Referral Hospital that has made us realize this idea. Thank you very much. We in the region are committed to improving efficiency and effectiveness in health service delivery and to jointly fix challenges in implementation this financial year and moving onwards. We are also aware that for the population to enjoy a middle income status by 2040, our health is key, and we need to focus on disease prevention, while also not ignoring the existing non-communicable diseases and the emerging ones. We know of hypertension, diabetes, epilepsy, depressive disorders, even accidents and injuries, to mention but a few. And districts are urged to put up more efforts there. The region has leadership and management challenges too. And this dictates the need to strengthen management of health services. As I talk, out of the 9 districts, only 2 have substantively appointed DHOs. That is Noya, myself speaking, and the Moro districts. This means 7 other districts have staff in acting DHO positions who have even acted beyond the recommended period and are still acting. The 7 health center forces in the region, of these 6 have substantively appointed doctors working them. And 2 of the doctors are already serving as acting DHOs, causing a gap in the health center force in which they are meant to serve in. Affirmative action in this aspect. We must take advantage of the extra wage that has been allocated to us this financial year. And we also urge that the doctors in the health center force be supervised by Gulu Regional Referral Hospital consultants. From the 2 days review prior to this assembly, we came up with a number of challenges in the sector. They have already been highlighted, which include understaffing. I've already talked about the leadership gaps, underfunding, with a large inter-district variance. We had a presentation which showed a big variance between districts. If you look at this, what the health center 2s receive and the health center 3s receive. But a little bit, the variances were not so big if you go to the hospitals, health center 4s, and the DHO's office. We have poor access to health services, some as low as 40.7% in Noya district. Yet the national average is about 75%. We have compromised quality of health services, high teenage pregnancy burden, limited supportive supervision in facilities, high maternal deaths in Gulu district, partly as a result of referrals from districts. Average indicators in TB HIV control, issues of data quality, minimal programs for key persons like sex workers and fisher folk, low water and sanitation health indicators, low nutrition indicators, inadequate infrastructure, some even dilapidated, including staff houses, ill-equipped facilities, stock out of drugs. Currently, we're badly off. We need something to be done urgently. Low levels of utilization and even establishment of youth-friendly corners for the youth. Our surveys have shown that the youth are, first of all, highly affected in all areas of health, in addition to poorly utilizing services available. We also have partners that are not uniformly distributed in the region, and it's affecting our implementation of the sector plans. We need to strengthen quality and effective monitoring and coaching of the health workers too in this region. We appreciate the efforts by Ministry of Health to upgrade Health Center 2s to Health Center 3s in sub-counties without Health Center 3s. Of course, it will ensure that we provide higher level care to sub-counties that previously did not have the Health Center 3s. But we only decry the slow procurement processes involved and pray that it will be improved. We as DHOs in the region pledge not to entertain issues of absenteeism and low productivity, as this region has just emerged from a war that took us back a couple of years in comparison to other regions.
I call upon all health sector institutions and organizations to support joint planning, implementation, transparency, reporting, and sharing of interventions and achievements. We should ensure we work with our other government departments as well, not only health, so that the social determinants of health are well coordinated and tackled to improve in conformity the health of the population. This regional health assembly has helped us to identify practical solutions to solve some of the issues and challenges, to enable us to implement them better this remaining financial year and moving on in the coming years. I thank you all for having attended this meeting and having deliberated so freely and having identified practical solutions that shall enable us to direct our implementation in a direction of victory. And I just pray that the resolutions will be put into consideration henceforth. As I talk right now, I think it's a time that I should recommend 2 DHOs who have recently retired. We have Dr. Alex Layo of Pade District and Dr. Alex Olwedo of Kitgum District. These people have served the nation, and more specifically the people of Acholi region, especially Dr. Alex Olwedo, who served for 23 years as a DHO. When you serve as a DHO for 23 years, then you know that this is a person who has absorbed a lot of shocks. I actually joked one day and he told me, you know, the shock absorbers are almost breaking. That's why I've retired early. He has actually retired early. But I pray that the environments in which we continue to work in will be more conducive so that we don't break our shock absorbers. Finally, I wish you all the best in your endeavors as we gear towards achieving universal health care and eventually health for all in the region, for God and my country. Thank you. I've been given the task of inviting the next speaker. You will correct me. The chair of MPs? Sorry, the chair of RDCs. Correct me for that. I'm sorry. You're most welcome, madam.
Thank you so much, Chair of the DHO. Your Royal Highness wrote Meke Kwa Acholi, RCC Gulu and all the RDCs, Mayor, District Chairpersons, and Secretary Health, our visitors from Ministry of Health, the development partners, Director, Gulu Regional Referral Hospital, DHO Emeritus, COWS and DHOs. Good afternoon. Thank you for calling me Honorable MP. Maybe it's a blessing. There was an issue that was raised yesterday and we all kept quiet, that the data we were presenting was cooked data. But I want to stand here and say the data was a correct one. Because I experienced what I saw here was what was in Omoro, the issue of gender-based violence, not reviewing maternal death, the routine immunization that had gone down. We were now strategizing how to improve. So the delegates here and the delegates joining us online, that was the correct data, and we need to work around and improve what we saw yesterday. The presentations that we got here is a reflection on what we have on ground. I monitor government programs, and I've met it. There was issue on referrals that you first do needs assessment, link here. I experienced that one night. A mother called me
an expectant mother. She had gone to a health center too. The midwife came and told the mother, you can't deliver, it's complicated. Go to Gulu Regional Referral Hospital. She left to go and sleep. So they called me again. I said, what? Let me talk to her. But I canceled her and told her, you are trained, you can handle. Just go. These people walked to the health facility. That is the kind of referral we have. But then when I talked to her, then they went to the labor. Barely 30 minutes, they told me we have a bouncing baby girl, and we have named her Susanna Kai. So you see that kind of referral. So we need to do a lot mentoring the health workers. At times they know what to do, but they tend not to know. So we need to work together. And the issue of data reporting. When you report, it formed a decision for your district. I experienced this. We were getting difficulties on reporting. Then the dose of the vaccine for COVID-19 we got reflected our reporting. So you report, it would help the planners to plan for you and report correctly so that you are supported. Support, supervision is not finger pointing, but mentoring. As you go out to mentor and you leave the place, let it be better than when you got it. But most of us go for fighting, finger pointing. Let's just take an example of oxen in the garden plowing. Keep hitting it. It will stop and say, kill me if you want. I won't work. So this is how we should handle human beings. When you motivate them, you encourage them, they will give you the results you want. But if you coerce them, they would say, okay, and they would make mistakes knowingly. So what do we do as supervisors? We need to make our subordinates friends. We shouldn't be bosses in our workplaces. And that's how we form the team spirit of work. And that's how we achieve together. Because you cannot do it alone. The 2 days we've been here, we've shared a lot of experiences. We've learned a lot, especially with the resident district commissioners. We've sat here, we've got a checklist of monitoring out of this meeting that will help us a lot. And our quality of reporting is going to improve because it's going to be based on facts that we've got from here. Thank you so much, organizers of this assembly. You've empowered us. I will now get back a different Susan, not the one that came the other day, because I've learned a lot. Thank you so much. Our partners, thank you for standing with us. Thank you, everyone. Thank you, our virtual participants, for being there. If it wasn't for COVID, we were all going to gather here and sit together. I always end by saying, may the good Lord bless and protect all of us.
Thank you, Madam Chairperson, the Chairperson of the RDCs of the region. It wouldn't be prudent if I did not give a minute. I was advised if I did not give a minute to the mayor of Gulu City, just to greet us, because he was represented yesterday here by his deputy, ably represented because she made a statement on his behalf, but we're in his city. So, Mr. Mayor, your worship, please. Just have a minute, because when His Royal Highness speaks, we don't talk. So I just wanted you to come in now.
Your Highness,
Allow me to observe the protocols. Ladies and gentlemen, my name is Okwan Alfred. I'm the city mayor of Gulu City. I would like to apologize. Yesterday, I was not able to make it because we were for a very serious business in Kampala, discussing issues of youth meet infrastructures in Gulu City. But today, I decided to come and attend this very important first health assembly in Acholi sub-region. I would like to make only observation, not speech. The first one is about the health disparity in the Acholi sub-region. If you see the UBOS report, Acholi regions itself is the most poorest part of the country, and that means health-wise, they are also not having a good health status. I would like to request the chief of the health workers in the Ministry of Health. I've seen they have started training from South and West, the community-based services or the community-based health workers. I would like to request them to plan also for this region so that we are not left so much behind with the current status of our poverty. That is my humble request to them. And secondly, I would like also to request this team to put the recommendation for the city very clearly. You know that now city is at the level of the district, but is above the district in terms of service delivery. And we have a very critical understaffing in the city. Much as there is no much structure now, but as the ministry should plan, so that we have the 2 health sub-districts, we have 2 city divisions, which both of them are having MPs and their constituency at the level of health sub-district. So we want them to be uplifted to the level of health sub-district, and also the city health office should be fully equipped so that we can stand on our feet to make sure that the health in the whole Acholi sub-region is taken care of properly and coordinated well. Otherwise, I would not like to start making speeches here. I request that the ministry and the doctor who have said there's some motorcycle for TB and leprosy programs, Gulu City, we shall also put our request according to the health centers we are having. But I would like to report here that we don't have even a single moving vehicle for the city, for the health department. Not only the motorcycle which is needed, but we also need at least 1 vehicle which is in a good running condition. Otherwise, thank you for this first meeting. I think it should continue quarterly or biannually so that we can exhaust a lot of issues that is within our sub-region. Thank you. Wish all of you well as you go back.
The agenda for the other meeting has already started for the motorcycle. But let's leave it there. Someone has already put his request forward. So only 3 motorcycles to go. Your Royal Highness, the Paramount Chief of Acholi, represented here by the Roto of Pateko, please give us your word. And immediately after, we shall arrange for certificates that you will hand over to our participants. You may remain where you are, sir. Is it not on? Oh, yes, it is on. You can move it closer. Just speak.
Oh, it's on, okay.
Thank you very much, Doctor, for doing a very good job moderating today, or being the MC. I want to thank my colleagues up here. I better call them colleagues. I want to thank the Ministry of Health, the Regional Director, Regional Referral Hospitals, the Health Paternity, the RDCs and political and all other officials that are here, development partners. We are very grateful for this. Excuse me, I can't talk well. I'm very grateful for this assembly. Although it's the first of its kind, it's very much welcome. Ruot, or Chief Collins Atiko of Patiko, which Gulu town sits in Patiko. I represent the Paramount Chief of Acholi, Ruot David Oneno Chana II, and I bring greetings. Just a little bit of history. My grandfather, Ruot Andrea Lagara. There's a road called Andrea Lagara in Gulu town here. He's the one who brought the white people here to start Gulu town in 1910, 1911. It's just for the background. If I had been asked to be an advisory, give advisory service to the medical fraternity, I would have refused because I'm nowhere near your professions. I want to start by giving you a story. When we were young, we would come to Gulu Main Hospital. Then it was called Main Hospital. Sometimes if you have malaria, you're given 3 injections, and we feared injections. So if I'm the one who came today, tomorrow my brother will come. Then the 3rd day I'll come, just for fearing the injections. My sister had a different tactic. If she were given oral medications like tablets, she would throw them past her mouth to the back and then drink water. Then my mother would be wondering why the condition is not improving, actually getting worse, to the point that she would be admitted in the hospital. Those were the tricks that we were playing when we were children. But today, on a serious note, what you do for this country is very, very important. The development of this country, and this region included, hinges a lot on the health of the society or the people of Uganda. The medical practitioners and all the related facilities and personals are valuable to us. You know, it's cheaper to avoid getting sick than to get treated. That is always a motto that must be addressed to the public, especially when it comes to hygiene, sanitation, all those things, which actually make your work very difficult because people get sick and then they come to redress with you when it could have been avoided. So it's not only important for the medical services, but also for us who are in the communities to amplify the efforts that the district health teams put up, having latrines, having things like those, and having sanitations. It's very important that we replicate the instructions. I think one of the best ideas that came from the Ministry of Health is the VHTs. I think that is a very effective model. We must really thank the ministry for developing that. Because in the villages, people know, they do understand. The communities do understand. And I think a lot of the things which have been discussed here yesterday and today can be channeled through those ways. I want to give you something we're trying to borrow from the VHT's model. For the last 2 months,
the formal justice system and the informal justice system, which is the traditional justice system. We have been working together to see how we can create a pathway where the informal system can cooperate and collaborate with the formal justice systems. And we're talking about how do we disseminate this information to the communities. And I was a champion of village health teams. I didn't even know I was coming here, but I was talking about the village health teams model, that we can use the same thing for dissemination of information. So I'm grateful to the ministry and the health fraternity for developing that model with a practical model. Early on, I talked about the post-vaccination issues and the noise from the social media and other sources to decampaign vaccinations. And I already talked about that a little bit earlier. And I think it's something that we should look into, trying to forcefully put our views forward for the correct information, not the absurd information which is being projected. And also I would like to request researchers and medical fraternity and the universities. I think out of the COVID program, we have seen 2 herbal medications-based treatment for HIV, for COVID, thanks to Gulu University and Dr. Lamara, Barra University and Dr. Ogwang. Those things are effective and they worked. So I would rather really want to encourage serious research into traditional medications and traditional herbal systems. I want to give you an example. In Gulu here, if you have a fracture or serious fractures, even Lacho Hospital will refer you to Koch medicine. I don't know how many of you know about the Koch thing. It's a herbal medication we put on the fractures. They're green. And the thing, as you heal, and it works very effectively. I'm pretty sure that doctors here will support my view on this. And it works very effectively. Actually, it stretches out the thing, and as it peels off, actually you're healing. So those are examples of collaboration that can be developed with the herbal medication. I remember when I was young, my grandmother used to use something actually called omompie. I don't know how many people know. It's a creeping plant that is around ant hills. And if you had very, very critical flu or cough or something, she would go and bring that thing and pound it and then squeeze them in your nose or in your throat. Within no time, 2 days, 3 days, you're okay. And I'm probably not far off to say that the COVID-Lice and COVID-X, probably some of them originate from that kind of plant. So we are seeing practical uses of herbal medication and traditional practice. I'm not talking about witchcraft. Let's divorce that completely from herbal medication. So because I don't want to give the wrong impression. I appreciate the suggestions here about coordinations of dissemination of information using the cultural institutions. It is very important. We've already been doing that. In fact, I've been campaigning about people getting vaccinated, those kind of attitudes and activities to continue. So I think we should all jointly campaign for this change in the budgeting system. Finally, I want to encourage that this assembly does not stop from the first one. It should always look at possibilities of having repeated assembly, either annually or biannually, whatever it is. But I think it's very important for exchanges and developments of new and effective systems for the health care sector and for the general public. Thank you very much. I want to thank everybody who has come here, the organizers, the partners who put up the funding, people who have found their time and committed their time to come here. We are very happy, and I'm very happy on the side of the Acholi Cultural or Traditional Institution to have been here involved in it. Thank you, and I wish you all the best when you go back. Thanks.
Ruot, with that, the assembly has come to a close. Thank you very much. Okay. Members, you clap, please. I made it through an assumption because I don't want him to stand up again to say that I've now officially closed. Okay? Ruot.
My apologies, the instructions were not very clear. Well, I would like to declare that this assembly is now officially closed, and thank you for participation.
Thank you very much. Ruot, as we finish up with the activities, the last most important one is the issuing of the certificates of appreciation, which you will be doing. I say certificate of appreciation. I was guided that the certificates were for the vast number of members here in their different capacities who helped set this assembly, the first of its kind. It's the first, the timeline has already been suggested, annual regional health assembly for the Acholi sub-region. So it's going to be here every year. That's the thing. Challenges notwithstanding, and so on and so forth, because this is our first. So I would like, pardon? Come, and we'll get this thing done quickly. So names will be read, and then you come over. Please, members, those who really actively participated around this thing, be around. The director is here. Barbara is going to get the names read very, very quickly. Members, you just come, get a handshake, a photograph for it, and we continue. Due to COVID now, you don't, you just wave. Please, just come and wave around here. Director, just read the names quickly. They will just come and wave to His Royal Highness. There's a mobile microphone. You can sanitize it as well, please. Who is reading the names?
Who reads the names? Okay.
Yeah, just go over it.
The first certificate goes to myself.
You can put it aside and wave.
James Justice Elima. The second is Sarah Biachika. I think this is the Commissioner Planning. Yes. The next is Dr. Martin Sendiona. Okay. Next is Dr. Dithan Kiraga.
Members, you hear your name, please come over quickly. We want to get this thing.
Next is Dr. Amandu Linus.
Please sanitize after.
Next is Dr. Timothy Amegovu.
Sanitize quickly after, please.
Yes, Amandu Linus, yes. Thank you. Next is Dr. Monica Imi. Dr. Ochula Dennis. Dr. Ochula Dennis. Yeah, thank you. Next is Mrs. Margaret Katusime. Followed by Mr. Fred Sebulo. Fred Sebulo. Next is Miss Beatrice Mugabire. Thank you. Next is Emmanuel Okello, Mr. Emmanuel Okello, followed by Peter Erem, Mr. Emmanuel Okello. Then next is Peter Erem. Peter Erem, followed by Dr. Janet Ola. Thank you, Janet. Next is Mrs. Immaculate Agedo, followed by Mr. Yoweri Diba. Thank you. Followed by Mr. Yoweri Diba. Yeah, thank you for your hard work. Next is Mr. Robert Omoro. Robert Omoro. If he's not around, so he's coming. I pronounced your name properly. Yes. Next is Mr. Stephen Kaliesubla. Stephen Kaliesubla. Very good. This is followed by Miss Margaret Mugisha. Thank you. Followed by Miss Margaret Mugisha. You're most welcome. Then the next is Miss Kabaichia Agnes. Thank you. Followed by Mr. Benson Odong. Then Dr. Patrick Odong. Followed by Dr. Judith Aloyo. Odong, you're most welcome. Thank you. Followed by Dr. Judith. Dr. Judith Aloyo. I think you can now have a seat. And then I can still move towards her, and we do from there. Yeah, thank you. Afoyova. Yeah. So you can see how easy it was to join the disability community. Yes. Mr. Luum Bishop Janan. It will be followed by Mr. Bob Marley. Yeah, Luum, thank you very much. Mr. Bob Marley, followed by Dr. Hilary Alima. The names are almost similar, but mine is Alima. Yes, thank you very much. Sister Liberata Amito. Sister, you are most welcome. Followed by Mr. Grant Katurebe. Grant is the ICT chief. Yes. Sister, you are most welcome. Continue serving the people of God. Thank you. Mr. Grant Katurebe. Grant, thank you for your work. Without this man, there would be no communication on the screen. Thank you for your team. Dr. Luke Lakidi. UPMB. Yes, it will be received by Dr. Alima. Yes. And then Dr. Alex Oluedo. I saw him around. Dr. Alex Oluedo. Okay. Yeah, you can pick on behalf of him. Thank you. Thank you very much. Mrs. Dragea Helen Iraku. Mrs. Dragea Helen Iraku. Yes, you are most welcome. Followed by Mr. George Olanya. Welcome. Mr. George Olanya. This will be followed by Mr. Sylvester Okot. Thank you. Mr. Sylvester Okot. Yes, very good. After Okot, we need Miss Jennifer Bakchiawa. This is a very tricky name. Jennifer Bakchiawa. You're most welcome. One of the main media people who helped us publicize this document. Yes, thank you very much. Yes. Mrs. Cinderella Anena. Thank you. Mrs. Cinderella Anena. Yeah, you're most welcome. Thank you. Followed by Mr. Charles Ojangole. Mr. Charles Ojangole. Mr. Charles Ojangole, you are most welcome. Followed by Mr. George Eyunu. George Eyunu. George Eyunu. Very, very good. Thank you very much, RBF. And then we want Dr. Drabe Rabin. Who will pick for Dr. Drabe Rabin? Drabe Rabin, that's very good. That was my teacher. He taught me surgery. Yes. Mrs. Goretti Kembabazi. Mrs. Goretti Kembabazi. Very good, thank you. You thank her. Mrs. Betty Ali. Okay. Then Dr. Walakira. Dr. Walakira. Dr. Walakira. Okay. Moses, sorry. Moses Walakira, yes. Yeah, you will pick for him, I know. Yeah, I know you very well. Thank you. Dr. Ochain Morris Emmanuel. Dr. Ochain Morris Emmanuel. And then Dr. David Ibuyat. Mr. David Ibuyat. Okay. Thank you. Mr. Okello, Moses Okello. Moses Okello. And then Dr. Felix Kaduchu, my dean. The dean, you can give it to the moderator. Yes. He is the deputy dean, the other one is the dean. Mr. Nathan Okiror. Mr. Nathan Okiror. Then Mr. Peter Abuola. Peter Abuola. Then Dr. Anna Lawino. Dr. Anna Lawino. Okay. Miss Anne Apio. Anna Apio. Miss Anne Apio. She's coming. I hope some are virtual. Some are virtual members, so they will get their certificates from the organizing committee chairperson. They will come. Mrs. Winfred Kinshava. Mrs. Winfred Kinsava. Then Sheikh Abdulrahman Kilama. Sheikh Abdulrahman Kilama. Okay, thank you very much. Then Dr. Betty Atai Ngamirano. Yeah, thank you very much. Thank you very much, and I think my function is done. Thank you.
Yes, thank you, Director. Your function would be done if I'd also had my name, but let me wave also. But that is fine. Thank you very much. I appreciate that. Ladies and gentlemen, first of all, give yourselves a round of applause for having spent your time here for 2 days in active participation and so on. And like you said, this is the first of its kind. It's our first regional assembly, and hopefully next year we shall be here again to see how our indicators have changed over the course of 1 year. As we close, an announcement here is that you did not just receive certificates for going home. Members of the organizing committee, please remain behind for a meeting.
So don't think that you are just coming up and about. So please remain behind so that we can have a review meeting after this. And to the rest of us, including the team, please, we shall go down for our evening tea. And after our evening tea, please, Johnny Masses, take leave and enjoy your time. See you next year, same time. After tea, going away is at will, is at leisure, okay? Keeping us together. Flexible team, and thank you for being that team. Ladies and gentlemen, Johnny Masses, I have signed out.